Good afternoon. Welcome to a 3-hour insurance negotiation extravaganza. So exciting. Post-lunch. I had an economics professor in college who, because I was in the era of blackboards, if he saw you dozing off, you just keep talking, he'd break off a little piece of the chalk and wing it at you. What I need up here, I think I need a squirt gun. I should bring a squirt gun. I'll do that. So, what you are about to receive is advice and guidance and information from 3 amazing insurance negotiation speakers and me. I get to open it though. This class that we're doing right here is a repeat performance of what we did for the AAP Section H NCE event. So at the NCE last year, SOAPM's title event, we did this 3-hour presentation. It was standing room only. It kicked butt. I was all right. Suzanne was all right. Suzanne was great. Kim was great. Polly was great. And in fact, one of the things that I liked about this is 4 different voices with different perspectives, all bringing different things to the table, and they failed to record it. So we said, oh, why don't we get the band back together? So what we did is we didn't talk about it at all. We didn't rehearse it at all. We didn't discuss how it went well and what we needed to change. We all just maybe made a few tweaks to the slide. So hopefully it's just as good, if not better, as last time. All right? We did, while we were there, all sit up at a table the whole time. So like Suzanne was next to me and she would nod. When Suzanne Madden nods at something you're saying that makes you look smarter, so it was great. Just pretend she's nodding at me while I'm up here. So we're not going to do that. We're kind of spread out. Polly isn't even going to show up till the second half anyway. All right. Our goal here, however, is to prepare you for the thing that almost no one does. Can I get a show of hands from how many people in this room have negotiated with insurance companies? A little bit more than half. Too often, I really just worked with a practice last week. I mean, I see all your numbers, and I was talking to someone. And I was talking to someone whose revenue was so low. This is someone in Georgia, which generally has pretty good rates, thanks to some IPAs in Atlanta. And her rates were like from the 80s. And I'd ask her, like, have you ever even tried talking to one of the plans, just asking them? She's like, no. You can't negotiate with the plans. And it just broke my heart because it probably cost her, small solo practice, probably cost that small practice $1 million, $2 million over the course of 15 years. All of which would have been in her savings account, her retirement account. That's what we're talking about. And we also know it's not exclusively about the money. It's about the terms of the agreements. It's about understanding the relationship. And Suzanne's really gold on this stuff, so we're going to get to that. My 45 minutes is to talk about this. We have our learning objectives because this is from an NCE thing. I'm talking about getting your data ducks in a row. Now I can do it. All right, I'm going to talk about the homework you need to do before we even begin this discussion. So here we are, insurance negotiation, round 1, ding, that's me. Now, here are some things I need you to understand. I may actually have you repeat them out loud with me, like we're in catechism class or something, all right? But here is what you need to get deeply ingrained on your soul. And one of the things I like about this presentation, to be clear, I take a slightly different perspective on how to do some of these things from Suzanne, and then from Kim, and then from Paul. It's not that I'm wrong. I don't for a moment think that the others are wrong. We just have slightly different flavors. So I want you to find the one that resonates with you. If you're listening to me right now and you're like, that's not quite, wait for Suzanne, or wait for Kim, wait for Paul. All right, but let's begin here. This is a business to them. They do not care about you or your patients. And that can sound like I'm calling them evil. I'm not yet. I might later. I'm just saying be aware that this is a business to them. They don't have feelings. You will not hurt their feelings. I'm looking right here at John Allen. He's like, Chip, read this letter for me that I'm going to send to them. And it was like super polite. And I'm like, cross all these lines out. They don't care. The person reading, the first person to open that letter, looks at that letter, determines what that letter is, and then puts it in this pile. But they don't put it in a pile that says, oh, but he was nice. There's no he was nice pile. To be clear, and I'm trying to use this term accurately, the insurance companies are sociopaths. They are entirely goal-driven and have no feelings. And the sooner you understand that all of the things that make you great as a pediatrician make you bad as an insurance company negotiator, the sooner you understand that, the better off you'll be. You have to have a different hat on. This is the business part. Number 2, the process is simple. There's no rocket science here. If there were a trick that I could just say, you know what, you do this, you say these 3 magic words, you get 10%, we wouldn't have this class. It'd all be secret. Okay? Actually, if I could get you all 10% more on your revenue, we wouldn't be in Denver. We'd be in Paris or somewhere, all right? It's simple work, but it's not easy work, which is why most people don't do it. It's like painting a house. There's no shortcut. And the squeaky wheel will get the grease. One of the things that makes it hard is because you have to check in on them all the time. Not like you send them a letter, and because polite people respond to you, you wait and you wait and you wait. Remember, they're sociopaths. You send them a letter, and then you send them a letter, and then you send them a letter, and then the letter escalates, and then you're on to step 2 or step 3. That's how it works, and that you are not wired that way. Last, no insurance company is prepared for a pediatrician with data. They don't know what to do when you show up with numbers. I guarantee you, the first 2 or 3 people in the corporate ladder you meet have no defense against your numbers. And it scares them. Sometimes just having the numbers is enough to get enough attention to get a new agreement. It's the same, lawyers know this. Lawyers, when you show up at that first meeting with the person you're suing, the lawyers have all this documentation, and the other lawyer goes, we're just going to settle. It's a similar thing. So get your numbers, and that's what I'm here to talk about. So the first thing you need to do, the 0th thing you need to do, if you're going to call Suzanne to do an insurance negotiation, the first thing she's going to ask you are, where are your contracts? You can't have any meaningful conversation about any of this stuff if you don't actually know what you have signed your name to. I'm not going to ask for hands because it's embarrassing. But many of you do not know where your insurance contracts are right now. All of them, at least. And I realize it's tricky. It's a game they play. You signed some 15 years ago, and you still have those, but those are not the contracts you've signed today because they evergreen them, and they slid some stuff by you, and 3 years later, you've got a different fee schedule and different rules and a different network and so forth. And oh, you want to get that contract? Well, you can't get it because you can't find a person. But the first thing you need to do is get your contracts. And right here on the screen, I have this. I stole this from Paul. It's just a quick, simple spreadsheet where the most common and appropriate terms of what will be in a pediatric practice contract are spelled right out. So you grab BBMCO, okay, Big Bad Medicaid payer, and you just run right through the effective dates, the renewal dates, the days due to cancel, which are right at the top on purpose, and you just run down through. Having a spreadsheet with all of this stuff gathered in one place with a link to your contracts where you can find it makes this process so much easier. Little things come from this. Yes? I want you, well, get to a microphone or yell. One or the other. Come on up. There might be a little switch. Now it's on. Try now. Talk loudly and I'll repeat your question.
I have no
It's on now.
idea where our contracts are. How do I get them?
So, are you touching that?
Okay.
Wait for Suzanne. She's the queen of this.
Okay.
All right. You love that question. Okay. Yep. And remember, they're sociopaths. They don't care that you don't know where your contract. They don't care that they don't know where the contract is. I mean, the number of PCC clients who are receiving money from insurance companies where there is no operating contract is significant. Things just keep rolling downstream, and you're on a fee schedule that you don't even know what the basis of it is. And if you want to fight about it, there's no contract to fight over because it doesn't exist. Who does that benefit? Insurance companies. They're not stupid. It's the only business where the worse you are at your job, the more money you make. All right? So, this tool right here, I'm a big fan of it. Now, so step 1 is grab your contracts. Step 2, run reports. There are so many reports in PCC where your stuff is on a silver platter and it's so beautiful and it even looks good. All right? Now, I have a shot here of my RVU calculator. That's for all the civilians who don't have PCC. Or I'm staring at one right there. The rest of you can tap a button and get a full RVU report by payer, by CPT code. Well, I just want to check one thing. Okay. In fact, it looks like this. You just tap a button. Go right to the pricing analysis RVU report per procedure. That's the first place I start, not the only. It's not first place I go. It's not the only one. What's the first one? Because this lets me go through and actually analyze. The first thing I want to know is, have they even been paying me what they said they would pay me? Well, let me rephrase that. Where and how much are they not paying me what they said they would pay me? With this tool and a little bit of spreadsheet work, and PCC is glad to help you, we can tell you exactly what percentage of Medicare someone is actually paying you. So if you have a contract that says, we're going to pay you 97% for your well visits and 110% for your sick, you can compare that. And you can do this for each of your payers. Another report that I start with, I run this report. If you are talking to me on the phone, I am probably running this report as we speak. And I'm not kidding. This is the per visit analysis by payer activity style, where it just goes by payer, your visit volume, how much your average charge is, how much your average deposit was. And it lets you know right away, look at this list, all right? Aetna, this is all faked, obviously. Aetna, the biggest one here, comes in at 165. Amerigroup, MCO, they're at 86, no surprise. Once, I can see what these are. Normally, what you look at here is there's going to be a payer who just doesn't fit. The payer, 9 times out of 10, is United Healthcare. Not always, but usually. All right? And this same document with the insurance names struck out, this is a spreadsheet. This could be a spreadsheet. So just remember, you can turn it into Scott and White can be INSCO 1, Amerigroup, INSCO 2, Aetna, INSCO 3. Oh, and then look, I know the sample size is weak, but UHC at 120, you can show them, this is what I get from these other payers. I'm not giving anything away. I'm not telling you what they pay. I haven't even told you who they are, but look at these other payers. Why would I keep you? All right? Step 3, I want you to dive into the clinical reports. Because the first step is gathering data retrospectively financially. What have they been paying me? What does it look like? How do they compare to the others? You're doing the business side first. Then the second thing you're doing is you're starting to assemble a clinical narrative of your practice. You're looking for the things that you do well, and you're looking for the red flags that they might hold against you. And you are going to ask them for, if you don't already have it, all of the payer-driven quality metric reports that they have. Find out what their pay for performance stuff looks like, and you're going to run all the PCC reports you can to match to theirs. And you're going to look at your well visit coverage. You're going to look at your screening coverage, your 99050 and 1, your IMS. Those first 4, those first 5, 6 are all in the dashboard. And this is what I'm going to tell you. If you go into the dashboard, and it turns out, was anyone here a dashboard winner today? Okay, what'd you win for? Bay Fortis, okay. I don't have that in the dashboard, but the concept is the same because I can get it for you. You're going to go into a negotiation, and you are going to talk to them about how you say, you can go figure out your math. Hey, according to Sanofi, every Bay Fortis vaccine, every 10 Bay Fortis vaccines reduces hospitalizations, 3 fewer hospitalizations in the community. I did 500 of them. Great. I just saved you, by my math, I don't even know, I already lost count, 50 hospitalizations. Well, they say, yeah, but everyone did that. I can help you show, no, actually, on a national basis, we gave out more Bay Fortis vaccine than everyone else because they have no compunction whatsoever at telling you that everyone else is doing better than they are. None. All right? You can pull right out of the dashboard performance measures against the highest performing pediatric practices in the country. And depending on what the measure is, we're down to the state level if we have enough people in your state. And for all of these measures, HEDIS publishes their own scores and so forth. So what you want to do is I'm asking you to do all this. I'll tell you about the ICD-10 stuff in a second. But I want you to come in here prepared for a discussion with the insurance company. And I want you to do 2 things. Number 1, I want you to be able to say, we're the best at this, and we're the best at this, and the best at this. What I don't want you to do is have the insurance company say, yeah, but your adolescent suicide screening is bad. And have you say, oh shoot, I didn't know. All right? You want to know every weakness your practice has before they tell you. Now the ICD-10 count, that's just something I like to do because there isn't a great and consistent pediatric risk score tool. I can't tell you right now if your practice has a riskier patient base than your practice because it's not well understood. But all of the work that is done through ICD-10 measures. They're looking for certain ICD-10 codes. And if I know that I might be sitting across from a payer, and I'm talking about my practice, let's say I'm in a 3-doctor practice, so I have about 5,000 patients. Among those 5,000 patients, I'm going to have this many with cancer, this many with mental health issues. I'm going to have a suite of kids with special health care needs in addition to all the well visit stuff. And I want to be able to say, this is why I'm saying it's building the narrative. I want to be able to say to that person I'm negotiating with, but I treat these kids. You're arguing with me over a $30,000 or $50,000 annual increase when you do all the math, yet if I say no to you, who's taking care of these kids? And what does that do to your costs? I just want to have those things understood. Their job, remember, your job is to see patients. Their job is to pay you as little as possible. They've been doing all this homework all along. You just need to catch up to them so you can actually speak without being surprised. All right? I'm almost done. So I also want you to look at demographic reports. I want you to break down your practice by age, sex, race, languages. I want to know where they are distributed by zip code. You can do some fun things with a little map. And I want you to, if you're not doing this already, please do this. There's a place in the EHR to do it. Track the employers of your patients. Because what you want to be able to know is that 50 of your moms all work here. 75 of your families all work there. Later on, this isn't part of my slide deck, but if you're having an argument with United Healthcare and you see the children of the CEO of a local company in your town who takes United Healthcare, a phone call to that CEO just to say, hey, I want to let you know I'm having a real tough time with United Healthcare. I don't know if you saw their $8 billion profit this quarter, but they're refusing to pay for that Beyfortus. And I know you just had that baby. I'm thinking about dropping them. A call from that CEO is worth 100 calls from your practice. So you need to start gathering the data. Who is buying these insurance plans? I then want you to grab, and this is all Googleable, which is why I didn't put it up here, because these links changed. But I want you to go online where possible and grab benchmarks where you can that are regional, national, HEDIS, or public. If you're part of a CIN, maybe the insurance company has their own version. The HEDIS stuff is Googleable. The AAP has some. PCC publishes a lot, and you have a dashboard that's filled with them. If there's a benchmark you're missing, write me. Maybe I have it. All right? Step 6, you need to start gathering your narratives and your storytelling. Now, I'm going to talk about the pictures at the bottom. One of the pieces that I like to do is just Google the name of the payer and the word like Cigna Quarterly Report 2024. You will find for all of these payers an article talking about Company X reports a $5.6 billion profit in that's in the first quarter as 2023 starts and strong for blank and health plans. All right? They brag about this stuff on the other side of the fence. This will be part of your negotiation. This may also be part of your messaging in the event that the negotiation goes poorly. Remember, your parents, they don't quite know and understand this stuff. And it's part of your obligation to keep them aware. Now, up here, I talk about your vignettes about your practice. One of the things that you're not wired to do is promote yourselves. And you're not good about telling stories about how strong your practice is. I don't have enough time to teach you how to do that well. But what you should do is anytime one of your families tells you something that you may not even believe to be true, oh, you saved my child's life. And you're like, no, I removed a Lego from his nose, but okay. Write it down. Start thinking about all the special moments that you had with these families. They also may become part of your story with them. All right? Now, I think I have 5 minutes. Where are you at? In the back? I have 20? Wow. I went faster than I expected. We might be done faster than we expected too. But 20? My internal clock is broken since COVID. I used to be like, I knew exactly what time it was. Now I don't. Before I continue a little bit, I think I'm about to get a question I was going to ask. Does anyone have any questions? Oh, Dr. Couchman, help me out. Yep. They are in the SRS library. Yes, they're in SRS. The fundamental billing reports are still on the partner side. I don't know if you saw that presentation, but we're actually right now very much building the elements of those old partner reports to put them into the report library. Many of the clinical reports, however, are on the EHR side. If you have any trouble finding any report, I suppose one of the great problems of PCC is we often have too many different ways that you can accomplish something. Just email us, just call us. Everything I'm talking about here from a report perspective is incredibly easy for a CA to help you with, and we're glad to do it. Question? So I would love to tell you, but I need you to grab a mic. And I'm doing this because Dr. Allen and I had a little discussion, and he's I don't want to call him a great pupil because that makes it sound like I taught him something. I really didn't. He just let me in on a process that he followed. And I mean, does this look like someone who owns a 75 doctor practice with offices in every place? No, look how laid back he is. All right. Tell him about your practice. tell them what you did and what the impact was, please. Hold on, just one sec. That mic isn't. Now go. Sorry.
Okay, when the student is ready, the master appears, and there was Chip. I have a 12 provider practice, and I'm a terrible procrastinator when it comes to the insurance negotiations. I'm one of those people who, no, I don't have any idea where that contract is for my lowest payer. We're about 60% Medicaid, but one of our insurance companies is about 15 to 20%, and they're by far our lowest payer. And there's no telling how much money it cost me over the years that I didn't do the negotiations. Prior to COVID, I was actually getting started and I was going to do the negotiations, and then COVID hit and it got put on the back burner. And then, so finally, I started thinking about it more, and I went into PCC and created this great spreadsheet. And I was talking to Chip, and he said, I could have got all that for you easily. So I wasted a lot of time creating my spreadsheet. But I sent them that letter. Well, actually, I had Chat GPT.
That's right.
Yeah, write me a letter to send to the insurance companies. And Chip said that was too nice a letter. So I took out some of the nice stuff, and I included data from I'm part of a CIN, and that's where my other private payers are. So I was able to tell this company that they were far below what everybody else was paying. And I asked for a 35% increase. They sent a letter back saying they would give me 10%. So I sent them another letter back and said, that's not good enough. I need more than that. You've not gone up on your payments in many years. And they gave me a 20% increase. And so I'm accepting that. And the person that I spoke to said, and we can talk again next year. But they were paying at a very low level, and hopefully next year it will come up. And we talked about some other things that they were going to push up the chain. They say, who knows? Like the G2211, they weren't going to pay that. The weekend codes, they still refuse to pay that. But we're going to work on that. So it turned out to be a good process.
So let me ask you two questions. At the end of the day, how many hours did you spend doing this negotiation?
4.
At the end of the year, what will the impact be on you financially?
Maybe $100,000.
Anyone here make $25,000 an hour?
Yeah. So
Right now, it's not always, and in fact, it's often not that easy.
yeah.
But I'm going to quote Katrina Skinner on this. You have not because you ask not.
Exactly.
Right? That is. I think Suzanne, Kim, and Paul and I agree. Like that's where you start. Or at least see what happens. Knocking on doors, you can eliminate and take care of some of the easy ones. Now, what I'm going to suggest, and I know he knows this, the reason that one went easily, they've been expecting that call for 5 years. And every year that went by and they didn't get it, just a little bit more went in their bucket. But how did you feel after that?
Oh, it felt wonderful.
Yeah, that's right.
That's and a little ashamed that I've been putting it off so long.
Right.
I just didn't want to grab a hold of that one.
So what are you going to do next?
I will have my data next year, and I will a year from this, probably a month before that contract is a year old, I will be talking to them again and ask for more.
And are you going to be talking to any of your other friends?
About
any of the other payers? Are you going to go after?
No, because everything else is through my CIN.
So they do that work for you?
They do that work for me.
That is I hope everyone here has a story like that next year. I mean, because we all want an extra $100,000. But I just hope the couple hours of work, it was 4 hours of work, the first 3 of which were just anxiety relating to getting the perfect letter, right?
That's right.
And how important was the perfect letter? Not at all.
Not at all.
Not at all.
No.
You could almost just send them a letter that says, Dear United, 30% or else.
That's right.
And it will go into that pile. It doesn't matter. The contractor you're working with isn't giving you points for being a nice person. And the problem is that you all live in a world where being a nice person and having that relationship is really important. There was a time when the relationships did matter, but overwhelmingly, these payers are moving to no direct reps, AI reps, overseas reps. There's no such thing as a relationship with any of those people, any of those things. So you can't do anything about that. All right, does anyone else have any questions? Thank you.
Thank you, Chip.
No, thank you. We're going to hear Suzanne. She is going to take you to round true.
Thank you, Chip. Always fascinating nuggets. I always pick up these little pieces, and I want to just respond to a couple of things that you said. Do not wait for 30 days before the contract renews. If you look closely at your contract, you'll probably see 90 to 120 days. Once you're inside that window, they'll say, oh, so sad. Looks like you're rolled over for another year. We'll talk to you in 15 months. So you can't talk to them too early. If you hit them up 6 months ahead of time, they'll say it's a little too early. You say, yes, but I have served you notice to renegotiate. So now the clock is running for them as opposed to for you and you being inside that window. So definitely make sure and do that. Is there a lot of feedback on this? Let me just see if I can make this sound a little better. Hold on. Yeah? Oh, good. Okay. So it's just my voice hitting me in the face from the back. Okay. The other thing about your negotiation, the CIN, are those wraparound rates that you're getting, or are those base rates? So by that I mean, do you get bonus payments, or do you actually have increases on what you get paid per CPT code? Okay. Okay. So shared savings are usually, and this is usually the case with CINs, so I want everybody to pay attention to this. If you're in a CIN, a clinically integrated network, or an ACO, an accountable care organization, those are typically what's called wraparound contracts. That means that everybody, every practice, stays on their own contract with the payer, which means whatever lousy rates you're getting are the lousy rates you're getting. And then the CIN or the ACO are getting savings in return for what they're producing through the CIN. That gets divided up and you get bonus payments, pay for performance. So you get a nice little pile of money and you say, oh, that's great, I've got some money coming in, but your base rates have remained the same. You can go and negotiate better base rates and still stay in your CIN because that's not the nature of the agreement that they have with the payer. So take a look at that and understand if you're getting paid for performance and you don't have any increase to your base rates, go negotiate your base rate. So I wanted to just bring that to your attention because you were very successful with that one payer. Don't stop there. The other thing is you can parlay what you have successfully achieved with one payer with the others. You can say, we would like to negotiate our contract. We have negotiated contracts and yours is 10, 15, 30% behind what we have with our top payer. We'd like to talk. That puts them on notice that you're not going to accept anything other than a negotiation because you've successfully negotiated with somebody else. You're also of the size that makes that possible, right? So what do you do if you're a solo doc? To Chip's point, if you don't ask, you don't get. Though I think he said it much more eloquently than that, but that is the simple matter. If you never knock on their door, nobody is going to come and say, hey, we noticed we've been paying you really poorly for about 12 years. Would you like an increase? It doesn't work that way. To Chip's point, they don't care about that. That's not the nature of their business. The nature of your business is to actually care. You're doing that every day. You're helping families every day. And you're in an industry where the insurance companies make profit at all cost, underlined, underscored, right? That means if you leave their network, they don't care. If families go without, they don't care. What they care about is what is our profit margin quarter to quarter, not year over year, quarter to quarter, okay? Where do they make those profit margins? They got the premiums coming in, right? What's their cost? Claims being paid. So whatever they don't pay you is profit. Whatever they can do to keep your rates as deflated as possible is profit, okay? So the profit is being made off of their delivery system. You're the delivery system, okay? So you need to push back. You need to push back on that delivery system. Cost of goods has gone up. You're the goods, right? Put them on notice with that. Okay, so with that, I'll jump into this. Okay, so as Chip says, it really doesn't matter what you say in your letter, but it really does matter the process that you follow to get it there. Because as you know, when you call an insurance company, it's the 1-800 good luck number, right? You call, you might get somebody. Chances are they're in India. Chances are they'll say, we'll give you a ticket number, or we'll give you some sort of support number or whatever, that I think they then just delete, right? Because you never hear back from them again. So you call again. The third or fourth time you call, they'll say, oh, we'll escalate the matter. To who? There's no one to escalate it to, so you still don't get a call back, right? And so that just goes on and on until you literally grow old and die. So don't let that happen to you. You really need to figure out what each payer has in terms of their process. And I've given you an example of one just so you can get a sense of how this works. So once discovered, send your request through. So why do I use the term discovered? It's not like you go to United Healthcare's website and says, you search, how do I request a negotiation, right? In fact, most of the payer websites, if you go to the Contact Us page, there'll be contact for claims, contact for pre-authorization, and that's about it, right? And credentialing. Where do I go for contracts? They don't want you to go anywhere for contracts. They don't want you to ever ask about contracts because they don't want to have to do this dance, okay? So how do you find out? How do you figure out? Well, we do talks like this. We, help you sort of navigate how to find it. Typically, what you're always looking for is network management. So if you ever do call that 1-800 good luck number, right, there will not be an option for network management. Credentialing is your best bet because there's usually somebody that will answer the phone or will get to you, and you say, I'm calling to inquire about my effective date, right? That's a good way to just get you, in with the credentialing people, because they'll be like, oh, your contract's been in effect for the last 5 years. They really, do you have a copy of my contract? No, we're credentialing. You'd need to talk to network management about that. Oh, great. How do I contact network management? Bing. Okay, that's how you get that information. It's also a great way to open a negotiation. You're asking for your contract. Why is it a good way to open a negotiation? Because as Chip said, most of the time, they don't have a copy, or they have a copy that's so old and it doesn't have all the addendums and all the various things that they have just added on top of your contract because they constantly sort of re-engineer the terms of participation. And so when you ask for that contract, one of two things happen. Either they have it and they give it to you, and you say, wow, thanks, Kim or James or whoever sent it to you. That's really handy for me to have, and I see it's like 2 decades out of date. So let's talk about, how we can negotiate better terms for ourselves, a newer contract, etc. The other thing that may happen is they'll say, we don't have one. There was a fire back in 1987, and apparently your contract was in it, right? I don't have a contract? Well, we better get a new contract in place then, hadn't we? And they'll say, oh, don't worry about it. You're still effective. I might be effective, but I believe there are federal regulations that requires you to have a contract, which is true. So then they have to produce a contract. They have to have you sign a contract. You say, well, I'd like to sign it, but the rates are terrible, or the rates have been the same for 10 years, so we really need to increase the rates. Once you have that going, then you want to do this. You want to include the information the way they expect to see it. If you did just send a letter, for example, that said, Dear United Healthcare, 30% or else, they'd say, what's your tax ID number? How many providers are attached to your tax ID number? How many locations do you have? We need a roster list. Who the hell are you anyway? And the reason being because they don't want to look up Acorn Pediatrics, or they don't want to look up ABC Pediatrics, right? They need that tax ID number. So usually it's the tax ID, name, location, a roster list, and then what are you asking for? They're not just going to offer. If you say, I'd like an increase, they're going to say, well, how much are you looking for? Because they're not going to offer you 20% when you might have accepted 5%, right? So they'll never, negotiate against themselves. They're always going to require you to ask. You asked for 30%. Great. You want to go high, not so high that they're going to be like, that's a joke. It's never going to happen, right? Where they just ignore you or say, we're not doing it, goodbye. And I'll talk about what you do with no. But you want to aim a little higher, right? If you say 10%, they'll come back with 2. And then you'll probably end up settling at 3 or 3.5. Aim for 30, they'll come back with 10 or maybe 5, right? Depending on what they're in the mood for, depending on whether they value you. And then you sort of go back and forth 2 or 3 times until you sort of get somewhere that you can live with. Write a short but compelling overview as to why you should be paid more. That's where the data comes in. We take care of 2,000 of your members. That's a compelling statement right there. They're like, oh, we have to pay attention to this. This could be a problem. Red alert, we've got volume. What are we going to do here, right? So you want to say how many patients you're actually taking care of. You want to talk about what those revenues look like. Talk about charges, though, rather than payments, because the payments are about 40% of what you're charging. At least I hope so, because you always want to charge high enough that if rates ever go up in a particular area, you're not going to be leaving money on the table. But what does that mean? If you're getting paid what you're charging, you're leaving money on the table, because they will only ever pay you what your charge is or what their payment rate is, whichever is less. Right? So if they're going to pay $100 on something and you bill them $90, they're going to pay you $90. Right? So look out for those patterns. Most of our clients, have their charges set at about 250% of Medicare. It's okay to be writing things off, right? It's okay to bill out $300, the payment is $100, and you write off the balance, right? Some people are like, I don't want to keep writing off all the charges. Why not? The lower you charge, now that's the new rate that you're willing to accept, right? That's how those sort of, fair, what were they called, Chip? The fairness in transparency, that Optum used to use to sort of set what were the usual and customary fees. That's where they're getting them from. What are we being charged? So the lower you charge, you're actually moving the bar down on yourselves and emboldening and empowering the payers to keep paying you less because they see that some are actually only charging a certain amount. So write that short but compelling overview. Why short? If it's 3 pages long about how great your practice is and how much your patients love you, it's going in the garbage first, right? Even if there's high volume, because nobody wants to read all that. Hit them with the highlights. We take care of a bunch of your members. Don't even call them your patients. They're members, right? We do $1 million in charges a year. We're NCQA recognized as a patient-centered medical home. We have these various programs, whatever it is. And if you have some key employers, to Chip's point, that's really important to track the employers. Why? If you're taking care of 20 families in a local law firm, those customers for the payer are really what the payers are most concerned about. The individual market and the marketplace stuff, they can take it or leave it, right? They have what's called a self-funded book of business, and those are their customers that are paying them a lot to really manage those benefits. Those employers actually write the terms of most of those benefits. If 20 families are all of a sudden at risk, that's a big client for the payer, and that's a client that gets to say, hey, we're paying for all of this preventive care, and apparently you're not delivering, or you're delivering at a rate that's so poor that none of us can live with this, and I have 20 families that are going to be really upset about that. It's disruptive to my company, right? They'll pay attention to that real quick. So if you've got some good intel on some, key employers that's in your patient mix, use it. Use it. Just float it. You don't need to say, and we're going to call them and we're going to let them know. Just float it out there. They're smart enough that they'll be like, uh-oh, that law firm's going to be a problem for us. Let's talk to them. And then follow up within the time frame that the payer quotes you on. So sometimes you'll send it through their designated, inbox, and you'll get a response that says, we'll get back to you in 60 days, but it might be 90. Don't follow up in, less than 120. Follow up at the 60-day mark. We submitted this. Or even follow up 5 days later. We submitted this. Did you receive it? Now you're going to be, annoying number one, right? Because now they're like, we said, don't call, don't get in touch with us for 60 days. And you say, okay, but I want to make sure you received it first, and I'll be happy to follow up in 60 days. Then you're going to get somebody that actually acknowledges it, because they're like, if we don't tell them that we got it, they're going to be annoying us for the next 60 days, right? At the 60-day mark, or whatever that happens to be, you follow up and say, I've waited patiently. Where are we now? Now they're like, okay, we got to move this one to the top of the pile, because they're on it, right? They're on it. They want us to get back to them as soon as they can. Squeaky wheel gets the grease, as Chip says. So you want to be that squeaky wheel. So here's an example of Aetna's process. So you'll see the URL, Aetna.com, healthcare professionals, forms, contact us. Why are we going through the contact us? Because nowhere else on their website is there anything to do with network management or contracting, okay? So this is a wonderful way to just be really irritating, because they give you the golden option of other. What's your topic? Other than anything you've given me, okay? So you go with other and you put in your information. What's really nice about the contact forms that the payers have on their websites is this stuff is tracked. They have to be able to respond back very timely to these. It could be anybody, that's messaging them. So they have to, get back to you relatively quickly on this to let you know what's up. So within 48 hours, we receive these instructions. Dear healthcare professional, because they have something ready to go, right? They know that people will and providers will ask them for negotiations. So they have this ready to go. If you want to request a renegotiation, as if they've ever negotiated with you, right? For participating providers, that request must be in writing on dated letterhead. Okay, pay attention to all the words. On dated letterhead and faxed. If you do it any other way, it doesn't get put in the right pile to then be looked at by network management, okay? I kid you not. All right, so dated, letterhead, faxed, that's the fax number, and it must say attention of network management. Otherwise, it goes in the loser pile, okay? So you gotta have it addressed properly, and must include the information below, okay? If multiple providers, each provider must be listed. They're not kidding. I literally have done this just for fun to see if we left something out or left out a tax ID number or whatever. And when we followed up, they were like, you didn't send the right information. It went nowhere. You need to start the process all over again. Okay, so provider name, NPI, tax ID, product type. You could say all products. Don't even bother trying to figure out which ones do we participate in or not. You can just say all. That's fine. All, plan type, all. Codes and amounts being requested. Codes and amounts being requested. If you just say all codes, 30%, that might get you kicked out too, right? So you could say, and your codes fall under these buckets: evaluation and management, screening codes, vaccines, vaccine administration. Find out the categories that your codes sit in, list all the categories, okay? And then what it is that you are requesting: contact name, contact number, email address, right? Please do not respond to this email, as this mailbox is not monitored. So follow that process or you hit a dead end, right? So absolutely do what they say and then follow up aggressively. All right. When you follow up, or perhaps they actually reach out to you, they're always going to say no first. Occasionally they'll say, okay, we took a look at this, we're coming back with a low ball. But usually they always say no. Why? Because they're trained to say no. I used to work for United Healthcare many years ago. And it's like, you don't ever say yes. You don't ever evaluate that. You say nope. Because when you say no, 80% of practices requesting will go, damn, we tried, but we got a hard no. Take no for no. No means nothing. No means let's keep talking, okay? So they say no, don't accept it and walk away. Once they say no, keep the representative engaged and build a case. Well, why are you saying no? We submitted a very reasonable proposal. And they might say, well, it's not reasonable. You're asking for 50% or 30%. Okay, what's your counter? It sounds like you have a counter offer for us then. What's your counter offer? No, we don't have a counter offer. But you said it was too high. So what is the right number, right? So you see how that sort of ping pong goes back and forth. You keep them engaged. You can ask them for other options. You can say, well, it's not an option for us to continue participating in your network unless we're able to do something with this really poor, awful, smelly contract that we want to put through the shredder, right? And they might say, well, what do you mean? Well, we're a pediatric practice. We're a patient-centered medical home. We have these wonderful HEDIS scores. That's where these clinical measures come in. Footnote on that too. Code and bill for absolutely everything that you do. I don't care if none of your payers pay for it. Here's the thing, if you never code it and bill it, you can never get paid for it. What's worse, if it's never coded and billed for, it never shows up in their data sets, and they will never change a policy to account for it, okay? So, for example, G2211, right? If you code and bill for it, it's showing up in those data sets. Then when they roll it into a policy, by the way, if you're not aware, United Healthcare, September 1st, is rolling G2211 into the E&M code. Their policy states, this is a covered service, but it's not separately reimbursable. So that means you can't charge the patient either, right? That's the key term. It's a covered service. If it's covered, you can't charge the patient because you participate in the network, but they're not going to pay you separately for it. Now, expect a fight. AAP will help go to bat on that, right, and get the fight going. But if all of a sudden everybody just stops billing G2211, then by early next year, where we might be gaining traction to get that code re-implemented, the payment reinstituted, they'll say 5% of pediatricians are billing this. It's a non-issue, non-issue. This happened to me one time a very long time ago, where I was fighting a negotiation, literally across the negotiating table, trying to fight to get 99050, 99051 paid for practice. And they pushed a report across the table to me and says, this practice has built that code 10 times. We've no idea what your problem is. Could have heard a pin drop. Boy, was I mad, right? If it isn't billed, it doesn't exist. They'll only go on what is in their data sets. So by the same token, if you're not putting that into your system, you can't get meaningful data out of your PCC system, right? Showing you how many times we've billed that. It's very impactful to say, we want you to recognize that the last year alone, we have billed 9905051 4,000 times, or whatever it happens to be, and you've paid 0 on that. Those are 400 opportunities that could have potentially been urgent care or the emergency room. That's a really impressive number. That's a really impressive statement, right? And you say, for that alone, we would like you to increase our rates. Otherwise, we would be happy to send your members to urgent care and to the ER because you don't pay us appropriately for the care that we're giving. That's impactful. Now they got a problem, right? Because you're not saying we're withdrawing from the network. You're saying, now we're going to mess with you, right? Now we're going to inconvenience your members. Now they're banking on the fact that you won't because you're pediatricians. You're too nice, right? You're too nice. You just need to raise the specter that you might do it to help sort of squeeze them a little to get them to the negotiating table, and that might be enough. Okay. If they refuse to engage because you're too far outside of the effective date, that's the other trick. They're like, well, your contract just renewed. Evergreened, that term that Chip used earlier. Evergreen means there's a clause in every contract that says you can terminate your contract by giving us 120 days or 90 days notice prior to the effective date or the anniversary date. And if you don't, you're locked in for another year. Imagine that. So they're like, we'll talk to you next year. Also pay attention to the fact that if they are negotiating with you and they ask you for data and you don't provide it to them timely, we had a client recently that kind of let the grass grow under their feet and they said, oh, too bad, so sad, you've already renewed, we'll talk again next year. And I'm like, not so fast. We're not going to play that game, okay? But they'll try that on you because the longer they can stall, the more profitable they are, right? Because as soon as they pay you more, that's less profit. And it's as simple as that. It's a straight line from money in, money out, right? So if we can move that money out by 12 months, that's more money in. Profits look better, okay? If they still say no, ask them how you can get to yes. You can say, I can see this is a problem for you, but it's a real problem for us too. Chip.
She's totally right here. If they say they can't negotiate with you because the contract dates won't allow it, I want you to think about that for a second. If PCC came to you and said, hey, we'd like to lower how much you pay us, but we can't because of the dates, you know how full of baloney we are. We could just say to you, hey, are you good with this? We'll redo the contract. And you say yes in a second. When they say we can't do it because of the dates, they are blaming the dates and the contract for the problem, when all they have to do is say, we'll just put new dates on it. So what they're telling you, when they say we can't do this because of the dates, they're saying we don't want to do this because it's to our advantage to not do it until we are forced to do it. That's the definition of a sociopath. You see, when they say this, they make it sound like they don't control all of it. Oh, we can't do it. I'm sorry. You missed your window. You could miss your window, and they could still renegotiate with you. They don't say to Walmart, sorry, you missed your window. All right? They can say it to you because they can. So everything she said is right. It just underscores to you how bogus this is and how you just need to reframe it in your mind. Sorry, that one always drives me crazy. Between two people who have a relationship, you can say, let's just start a new contract. They rarely do that. So, sorry.
Yeah, and they will always default to the terms of your contract, right? And the terms of your contract will say you must provide us notice with 120 days or whatever, right? So they will default to that. They don't want to do non-standard things. So the more prepared you are, and by prepared I mean if you have a contract in hand, you can clearly see what that is. If you don't have a contract in hand, go through the credentialing department, ask them for your effective dates. That will let you know what your anniversary date is, and also request your contract at that point from them, and they'll help get you in touch with network management. But that will help you know. So like, for example, if you call tomorrow and they're like, oh, your effective date is August 1st. All right. You trying to get a negotiation, done by August 1st is not going to happen anyway, right? But be prepared for the fact that they might say, okay, but it's not going to be effective until the following August. It's going to take you 4 to 6 to 8 months to negotiate a contract anyway. It's very rare that these things happen real fast, right? First and foremost, you have the waiting game. We'll get back to you within 60 days. Could be 90, might be 120. Depends how on top of it you are, right? So there's 2 to 4 months gone just like that, right? Then when they start talking to you, there's the back and forth that has to happen. Never accept their first offer. They're always going to lowball you. Why would they give you their best offer right out of the gate? They're going to expect that you're going to try and counter anyway. So they're going to leave some wiggle room there. If they offer you 5%, that means you can probably easily get them to 7 or 8%. Okay? If they offer you 10%, you can probably get them to 12 or 15. All right? But never accept the first one. I had a client once that said, oh, this is great. This happened really fast, and they're willing to give us 7%. Will we sign? Will I tell them, go ahead, cut the contract? I'm like, not so fast. Have them give you the fee schedule first, too. 7% on what? That's the other piece. 7% in aggregate. But does that mean your preventive care visits are going to take a hit while your sick visits go up? Where are the adjustments being made? Depends on how the payer is benchmarking their fee schedules, right? Their payment schedules. Some have it based on a percentage of Medicare. Some say we're based on RVS. Okay, is that Medicare for my region? Is that national? Show me what your actual fee schedules look like. They'll send you a sample fee schedule. The fee schedule might even say, we pay you 106% of CMS 2020. CMS national, CMS local. Is it actually in my locality? Is it a neighborhood over? Right? So you want to ask these questions and you want to find out, exactly what the dollar amounts are. And if they're leaving you to calculate it out yourself, you go to PCC's website and you Chip, what is it called now? BYO RVU? Bring your own RVU? Do RVU calculator?
Free RVU calculator, you will find it. But everyone in this room, except for one of you who left, sorry, everyone with PCC, it is a report in our system. Tap the button, and it spits it right out.
Yeah. Yep. Because that'll run it all out for you, right? You also could save yourself. You're lucky because you've got PCC. For anybody else, they don't have that at their fingertips, right? And then you're looking stuff up on CMS's website, only to find that pediatric preventive care codes aren't there because it's Medicare, right? They don't have pediatric codes on there. So then how do you gap fill it? And it's a whole bunch of nonsense. So you definitely want to make sure that you know exactly what the per dollar rate is on every single code, okay? If they won't give you the full fee schedule, most of the time they will. If you're in a negotiation, they'll say, well, we can't, it's proprietary. You say that's an absolutely ridiculous position. Send me on a spreadsheet what your fee schedule is per code. Sometimes they don't have it yet. So for example, I've just spent way more time than should have been expected, but about 6 months trying to get a fee schedule out of a payer because they didn't build the fee schedules yet. So we had this ridiculously convoluted conversation around what the increases were going to be without actually using a fee schedule to base that on. Well, we'll give you 30%. 30% of what? 30% on every code? Are we taking the exact codes and lopping 30% on that? Well, no, we're going to shift to this percentage of Medicare and whatever. Okay, so give me that fee schedule so I can run it out comparative to what the practice is on today to see exactly what's going up and what's going down. Well, we haven't built that yet. Well, then how do you know what they're offering? Well, we're offering a percentage. What's the dollar amount? This literally went round and round and round and round for months, okay? I, of course, as of yesterday, have these fee schedules in hand, because don't give up, because here's the other thing. And this is sort of what started it on that particular negotiation. They sent a handful of fees, right? 30% increase was indeed there on the preventive care codes. What's the offer on the sick visits? Well, the sick visits decreased. Why would the sick visits decrease? Because they're financing the preventive care codes. You're not getting 30% on top. They're taking from here and they're sticking it on over there. So in aggregate, what's your dollar amount is always going to be the fundamental that you want to go for, okay? Forget the percentages. What is it in aggregate? It might be that they decrease, especially if it's a move on your Medicare base years. we had a nice run for a while on the RVUs on the vaccine administration codes, but it was short-lived, right? It was very short-lived. And newer Medicare fee schedules, the RV values on that decreased substantially. So what you'll find is if they move the base year to a base year that doesn't have a really nice RVU value on the vaccine administration fees, the decrease on the vaccine administration fees alone could completely wipe out and negate any increases you're getting on any other codes. So I say all of this to say, you want to assess what the offer is, you want to run out every single CPT code, and then you want to take a year's worth of utilization and drop it in to calculate it out, right? So if you have some codes that are going down by $2, don't panic. You might have others that are going up by 25, right? The key piece is running it all out and adding it up at the bottom, okay? And that will tell you what your actual overall percentage and dollar amount increase is going to be. Don't accept their first offers. I've said go at least 3 rounds. By the 3rd round, they're getting upset, right? By the 3rd round, they're like, listen, we worked with you here. We gave you a counter offer. It's time to sign, or we're just walking away. We're not doing anything further here. When you get to that point, you say, okay, all right, we'll lock in on those rates. Assume you want a 3-year contract, Mr. Payor? Why, yes, we do. Great, I'd like escalators in year 2 and year 3, and we can close the deal. Wait, we didn't talk about escalators. We're talking about escalators now. We've just agreed rates. If you want a 3-year deal, I need an escalator in year 2 and an escalator in year 3. What's an escalator? It's a cost of living increase. Usually they'll give you a 2 to 3% increase there if you ask. Sometimes they'll say, no way, no deal. And you say, then I can't sign a 3-year agreement. We can't be at the same rate basis 3 years from now as we are today. That'll either get them home, or they'll say, okay, we'll give you a 2-year deal and we'll give you 1 escalator. We'll give you a 1 percentage point escalator or whatever. You're still going to be 1% point ahead by the time you get to the end of that. So take it, okay? But do not put escalators on the table until you've actually locked in what the rates are going to be. Otherwise, you're just going to decrease the upfront to finance the escalator on the out years, okay? So you save that until you've exhausted them and then get them up with that. Focus on the codes that are highest volume and those that may be lagging. Sometimes you'll have a payer that'll say, look, we're not willing to do a whole new fee schedule. Where are your pain points? What do you want to focus on? And we'll increase, some of those. If they're paying you particularly well on preventive care, leave it alone. Look at where you're getting the deficiencies, right? Look at where you're really hurting. Often it's on the screening codes. Often it's on things that get bundled in. You had mentioned they're going to talk to you about the 99050 and 51. Often these codes are by policy bundled into the E&Ms. They can't, even if they wanted to, they can't do something different for you than what their codes, their claim system is programmed to pay you on, okay? So even if they want to give you the 99050 or 51, they can't. They can't reconfigure the system. Probably because they had a policy that said they could switch on the 050, but not the 51. So watch out for those. Where they say we can't, we have a policy in place or a claims edit in place, we can't do it even if we wanted to. You say, that's okay. We're going to add that to the E&M code. That's all right. That's worth about, $100,000 a year to us. So we'll just increase the 99213 so that it's worth $100,000 more a year to us. We'll accept that. That's okay. We can work with you. Okay? And watch them try and back away from that real quick. And they'll say, but you said you recognize that we're, saving you all this money. We're only asking that our share get rolled in. And if you can't do it on that code, you can do it on others. Chip.
I want to add that you have the special additional bonus of having people who will help you analyze these contracts, because one of the things you hear some consultants say is, look at the top 20 codes, look at the top 25 codes. And that's where they get you. They play a little shell game. They'll move. I've seen this so many times. They add to your well visits, but they take 50 cents or $1 off your admins that you don't really notice or care, but you do 4,000 or 8,000 of those. And that's where it comes back. Now, they also know that those are codes appear at the top, so they get the stuff in the bottom. The bottom 15% of your revenue, if they turn that down by 30%, there's a 5% cut right there. So get all of your codes, get all of your volume.
Yep.
I will drop it into a spreadsheet for you, and then you can plug their fee schedule in and actually see what the real impact is. This is a game they play that they're very good at, but we're good too. And Suzanne is good too.
It is truly all about running the data, and Paulie's going to, really hit us in depth with that. There's another game that gets played, and it's the bait and switch game. They'll give you a new fee schedule. You'll run out all the numbers and say, this is ridiculous. You're taking money off the table. How on earth can we possibly agree to this? They say, well, you wanted a new fee schedule. These are our latest fee schedules. What they're trying to do is make you back up real fast and say, okay, we'll stick with what we got, right? Because there's a shock that you get hit with to the system when you run it out and say, this is a $30,000 decrease. What the hell are you playing at? What are you doing? This is our current fee schedule, right? They're trying to show you, like, you think you got a bad deal? This is what we're paying, new kids on the block. So you should be happy with what you've got, right? And sometimes that works. I've had conversations with clients that have said, oh gosh, they offered us this like crummy thing. It was like, Medicare 2020, and when we ran out all the numbers, we're going to lose a whole bunch of money. So of course we just, like, at that point backed away from it. I'm like, no, that's not the time you back away from it. That's the time you say, so then we need higher increases on each of these categories if you're moving us to a new basis, right? A new Medicare year basis, okay? So watch for that. Aetna likes to do that quite a bit. The Aetna market fee schedule, this is the other thing. Don't assume when they're talking percentages to you that they are referring to Medicare. Aetna constantly references the Aetna market fee schedule. What's 100% of the AMFS? Who knows, right? You have to ask them for it. Give me the fee schedule, because who the heck knows what 100% of AMFS is on a 99213. So then they'll send you the fee schedule, and then if you decide, just for kicks, to throw it to Chip and say, compare that to percentages of Medicare, you'll see it's all over the place. Might be 68% of Medicare on one code, 135 on another. It's like, how did we even get here? Aetna, how did you get there, right? They got there because it was a homegrown fee schedule, right? So they're not even trying to benchmark to Medicare. So you always want to make sure that you understand exactly what the fee schedule is. Ask them for those rates, okay? And then, as I mentioned, wait until you agree to the final numbers. Okay, everybody's happy. They're like, finally, they're going to give up. Finally, we got there. Not so fast, right? That's where you throw in the escalators, and you pitch it to them like, I know we're exhausted. We've done really good work here. We're pretty happy with the rates, and we'll sign if. Just give us those escalators, and sometimes that'll get you home. They'll just be like, God damn it, here you go. Just sign the damn thing so I can get on with the rest of my job, right? They're humans too. They may be sociopaths, but they're humans too. Okay, and then what if the agreement carries risk? It's not all about the fees, my friends. It's not. Payment's not a payment if you can't get paid, or if you get paid on it and they take it back, or if they're withholding some of it because you didn't meet certain measures and it all goes poof, okay? So you want to really understand what you're agreeing to and the terms of your agreement as well, all right? It depends what state you're in. Anybody's in Florida? Anybody here from Florida? I'm sorry. I'm sorry. Because what's going on in Florida is sort of a good example of just how far payers can push risk. Where literally, and it really doesn't matter the size of your practice, a lot of these contracts now are saying, you must meet certain standards, you must do certain things. If your scores, your HEDIS measures, fall below a certain percentage on various things, you will be fined, basically. We will withhold 10% of your payment. What? Okay? And they're the ones that are measuring you. So you need to always have really good data. You need to make sure that if you're signing any of these contracts, heaven forbid, but sometimes you have no choice, you want to know, what are the terms, what am I managing to, how do I stay on top of it, right? So you're constantly going to be hitting that payer for data. They should be giving you that data every quarter, and if their data isn't matching your data, you need to take them to task. You don't wait till the end of the year when they say, oh, so sad, you missed your targets. Now you don't get paid for the rest of the year, right? You want to stay on top of that. So understand that risk, understand where that falls. And if there's some really nice language in there that says, good news, if you meet these targets, you get extra. We're going to pay you bonus money, and we're going to do these sorts of things, and it sounds great. Ask them, where do we sit now on those percentages? Because if the bar is way high, if you've got to turn around an improvement of 20% to qualify for the extra gold, how are you going to get there in a year, right? So you always want to say, well, where do we sit now? Some of these contracts are so convoluted that to try and figure out the math, what's the equation, right? Because they'll be like, well, we have this shared savings pool, we have this risk pool, we have these clinical measures over here, we do the hokey pokey over there, and then maybe at the end of it, there might be 2 cents for you, right? So you're trying to track that through. So always hit them up and say, where is my practice now? Run my practice through your math and tell me what I get. If nothing changed for the year and I sign this contract, what do I get at the end of it? So then they have to actually run that through their equation, and you'll see very clearly whether it's worth you signing on for that or not. And it's okay to say no. You don't have to participate in every plan. You don't. So be discerning, be selective. If you do end up signing up for risk, look at stop loss insurance, okay? Because what you don't want to have happen is you miss a target for one reason or another. You can work as hard as you can. Maybe partner number 2 and 3 aren't working so hard. Maybe somebody's out on disability. Maybe something goes wrong with the practice. All of a sudden, 10 or 15% of your income just went poof, right? So you want to have some sort of insurance if you do have some of these contracts. Just like any other type of insurance, it's for your protection, okay? So if you need it, you can tap into it. But I hope this is underscoring for you the severity of don't sign any of these contracts, okay? Because if you've got to sign a contract that you got to get stop loss insurance for, or you might lose your practice over it if things go south, that's not a contract you should be signing, okay? So it might be great. They're offering you huge rates, but make sure you understand what it is that you've actually, what you're signing on for. Set reasonable terms and timelines. Stepped approach works best if you are meeting these certain clinical measures, right? If they say, you must improve by X. Here's your HEDIS score today. You got to get to there. Say, we can't get there in a year. We could do it over 36 months. We'll sign on for a 3-year contract. And at the end of the 3 years, we expect to be there. They'll often work with you on that stepped approach, okay? But make sure you understand where the gap is. And if you're at that level already, make sure that you lock in that it doesn't change, that they can't move it up year over year, all right? You want to lock in where you're at because then you can maintain that and get the dollars. So again, be really careful about what you're signing on for. And then tie any incentives that you can to base rates. Pay for performance is fine until that dries up, right? You're being incentivized to move the bar higher. What happens when you get to the bar? There's no more cost savings there, right? And all of a sudden you don't get any more bonus payments and your rates are still in the toilet, right? So wherever you can, have them move those rates upwards, all right? Tie it to increasing what you get paid for the work that you do, as opposed to just a lump of cash that could go up in smoke at any time. Okay, so I'm going to turn it over to Paul. I think, do we have a couple of minutes for questions? If there's any? Okay. Okay, all right, so we have a little time. Any questions other than everybody's depressed? Sorry for the Debbie Downer news. But seriously, if you go in prepared, then you know what you're doing. So just a quick recap. The rates are not the rates if you can't get paid on them. The rates are not the rates if they're tied to measures that you have to meet that you can't meet or achieve. So just watch out for the landmines that are inherent in these contracts. If a payer is just giving you an amendment for a fee schedule, just saying the terms of the existing contract remain the same and we're just changing the fee schedule, that's a good thing. Don't push for, no, let's get a new contract instead, right? Because chances are the older contracts don't have a lot of these landmines in them, okay? So that's a good thing. They're just amending what you've got already. If they put a whole new contract in front of you, client just sent me one the other day. She said, oh, we wanted to be added on to the marketplace plan. They've given her a whole new contract that actually hits the PPO plan, the HMO plan, EPO plan, and everything else. I'm like, wait. These rates are entirely different than what you're on now, and this would replace what you've got. To Chip's point about effective dates, it's a new contract. So the old contract goes out the window, and it would have taken hundreds of thousands of dollars off the table. And she was like, I just thought I should run it by you before I signed it. Didn't even know what she was signing, okay? She thought, great, we're being added to this other plan. We're fine. And it had to do with so much more than that. So be really careful when you get those new contracts too. Question?
So I have a small practice, and my 2 worst private payers, excluding TRICARE and the VA, are, well, it's the same acronym as the user conference, those 2. And they're only in combination about 5% of my total patient base. So it's really a small number, but they're not good contracts. In fact, I actually don't even think that I have one with the C company. because they don't seem to be able to have it. And they took me off one of their plans and had a wrong tax ID number associated with my NPI. So the question is, how do I create leverage with them when I have very few patients? And I have limited geography. I mean, I'm in a rural area, so there's not a lot of other options. In fact, in one of my counties, I'm the only pediatric provider. So, I
See,
don't know.
that's your leverage right there. So your letter starts with being the only pediatrician in this particular area for X number of miles. I understand I'm essential to your network. As an essential member of your network, I need to make sure that I can get paid an appropriate amount as compared to the other payers that I participate with. Now you've got their attention. They're like, oh God, we don't want to lose this guy out of the network. Now we're going to have a hole in this county, and that's going to be a problem for us. Because that's the other thing. They have to maintain a certain network, right? They have to maintain certain coverage in order to be licensed in those counties in any given state. So you're at critical need, right? And so you want to highlight that for them. They're not going to come to their own conclusion about that. You could write in and hope they know who you are. They're not. Paint the picture for them. You got to do their thinking for them. And just say, and all I'm asking for is a 25% increase on your current rates. And they'll be like, well, I'm not going to give them 25%, right? But they'll come back with 5 or 6, and you say, I can't do it. I'd really like to stay in your network. I'd really like to take care of these few patients. I understand that if I don't stay in your network, that could provide, a licensing problem for you. So let's keep talking till we can get to something that's mutually beneficial. They'll look at it and say, in reality, it's a $30,000 or a $10,000 increase or whatever, and they'll be like, fine, here you go, right? So use that leverage for sure.
Yeah. So it's an advantage actually that it's a financially inconsequential decision for them. Okay.
Okay. Other questions? Yeah. A little closer. Oh, it might not be on. Okay, yell and I'll repeat your question so everybody can hear it. Right. So the question is basically, I know nothing about contracting. If I'm reading a contract, it's Greek to me. Who can help me with that? People like me, Chip, Paulie, we're your resources basically to be able to read through that for you. Or you can hire a lawyer. The problem with having a lawyer review it, very expensive. Oh, that's okay. Yep. So you would use resources like me, Chip, Paulie, we're your go-to people to help parse that out. Or you can use a lawyer. Lawyers are expensive, obviously. The other thing too is you need to pick the right lawyer. You need a lawyer that is really fluent in payer contracts. Otherwise, you're paying for their learning curve. They're going to read terms like shared savings and clinical measures and whatever and not know what that is. So always just sort of run it by your friendly neighborhood network here of Paulie, Chip, Suzanne, and we can help give you guidance on that. Also, take it to SOAPM. If you're a member of SOAPM section on, yep, okay. Throw it out there and say, anybody want to help me with this? Somebody else might be like, I just signed the very same contract. Let me tell you what you need to know, right? They'll share the love, share the information, share the wealth. So, so definitely, take advantage of your network. Okay.
So my name is Paulie Venturi, and I am with the Pediatric Management Institute. And this has been sort of a marathon for you guys, hearing all different things about managed care contracting. Admittedly, this is going to be the shortest segment of the entire day. And then after I get done, Kimberly Bunning's going to come talk and wrap it up for the day. What I am going to propose for today is sort of putting on my CFO hat and look at it from the numbers perspective. Because Suzanne and Chip have given you excellent information as to how to evaluate the contract and stuff. And it's going to be complemented with what Kim's bringing. But I want to look at some of the nuts and bolts of what is going on and how to evaluate these with the spreadsheet. Several years ago, I was dropping my daughter off at ballet. And y'all like a good story, right? I'm going to tell you a good story. So I took this picture right down the road from where she was going to ballet. And I just thought it was kind of interesting, and I always look for an excuse to put it in a slide deck. But the story behind this picture was that my daughter, who's 15 at the time now, she was little, and she was probably 8 or 9. She was taking ballet. my wife had bought some dehydrated garlic on sale at Sam's in a big bucket. And my daughter really enjoyed eating them. And over the course of 24 hours, ate the entire bucket of dehydrated garlic. And so we could not send her to ballet for about 4 or 5 days. And so finally, when I was able to bring her back, that's when I took that picture. So hopefully that doesn't make it into the World Wide Web forever. But yeah, so, but the point of this is that, you know, Medicare contracting, all the finance that goes on is about your relationship with your patient. And that's really what's going on the financial side. And based on your relationship, whether it's positive or negative, it's going to have a significant impact on the financial performance. This is a typical example of what we will see in a practice. We may have a practice that's generating just over $1 million. They have some expenses, they have overhead rate, and how much is left over to pay the provider. This is not an uncommon scenario. And what ends up happening is, what happens if we see a slight decrease in revenue, but our expenses remain flat? Does that ring any bells for anybody? Yeah. And what happens is your overhead rate goes up and reduces the amount that you have that you can pay your provider. Well, the variance, that 10% drop in revenue, has a 3-to-1 impact on your net income, on how much you have available to pay the provider. And that is significant. And so the first step in the next 25 minutes is to recognize that a small percentage has a compounding effect on how much you can afford to pay your provider. The opposite is also true. If we can effectively negotiate contracts and get our rates up 10%, then we see a significant increase in how much we have available to pay the providers. Now, be realistic. It is very rare. I haven't heard about someone getting a 10% increase in their payment rate. But it illustrates the point that when you see a drop in revenue, there's a significant compounding effect on how much you have available to pay the provider. Because that's really what the finance is looking at. So how do we monitor this? How do we look at these types of things? And this, we're going to walk through the next 4 or 5 slides or simply spreadsheet, and I'll give you the QR code where you can download them. So don't worry about trying to draw it. I'll tell you exactly where to find it. So here, we line up 5 payors, what our total charges were, our adjustments and payment, what our net AR, the change in AR, charges minus adjustments, minus adjustments minus the payment, what percent of AR, what our gross and net collection rates are. This gives us a snapshot over time, and I like running this on a year-to-date basis, a trailing 12 months. I can keep a good eye on what's going on and what may be occurring within the practice. Now, if I look at these rates and I see these numbers start to move around within the payors, it begs a few questions. Hey, what's going on? Was there a hold up in the claim? Was there something called Change Healthcare screwing up the delivery of payment? Those types of things. So this is a very quick and dirty approach as to how you can assess different payors within your contract. Generally speaking, I'm not gonna, if I've got 4 payors that make up 80% of my business plus Medicaid, I'm just gonna do those 4. I'm not gonna do every single one I have, right? So when you cover about 80 to 90%, that's close enough. That makes sense? So what we also wanna do is identify and look at the EOBs and compare the rate. Because you have contracted rate, but then you have what they actually paid you. And you know what's weird? It always seems that if it doesn't match up, it always favors the insurance company. I've never seen a situation where they promised to pay me $10 and they paid me $12. You know? Has anyone ever seen that? No. That's the reason we need something very basic like this. And admittedly, I don't know PCC well enough to know, hey, this is where you go. Chip, if you want to chime in on this, welcome to. But this really does help the entire billing staff. Yeah. But Yep. So this is really helpful for your billing people so that when they're posting payments, they know exactly what each of the payers are going to be paying. The top 25, 30 codes are going to cover 90% of your business. So it becomes helpful, particularly when we look, and then what I would probably look at is some of the vaccine drugs, but pretty simple. It's a very straightforward spreadsheet that we can look at. The reason we want to do that is look at it is there are some functionalities within Excel. How many of you like to use Excel? Okay, it's pretty simple, it takes a little bit of practice, but there is a function in there that can tell me, of these 5 numbers, which one is best and which one is worst. I can tell you right now, payer number 5 happened to have been Aetna for this particular contract review. But, did I say that out loud? But at any rate, we look at it and you can quickly visually see, payer number 5, you're the lowest on every single CPT code. So with this, we can also look at what is our current Medicare rate, how does each payer's rate compare to Medicare. So in this particular case, payer number 5 was paying less than 90% of Medicare across the board, whereas other payers were paying between 100 and 130% of Medicare. This is an exercise that I would probably do, I would update it. Depending on how well you do this, if you notice some changes, you can set it up to automatically load here, just to keep an eye on your payment. And how many of you have heard the name Lynn Kramer? Okay. She is famous for basically identifying payer number 5 as your lowest payer, and every September, she sends a notice of termination. She did not care if they had just renegotiated the contract the year before. Just trimming the tree, cutting those low payers, and eventually getting an overall lift. Anyone want to guess why September is a good month? Pardon? Yeah. The reason I like September is because if you give a 90 days notice, you are now into November, right? What happens in November? Open enrollment for the employers. That is the best time, if you're going to cancel a contract, to consider terminating that contract. Because that's where you're going to get the most support. Because as soon as the parents go in and see, hey, you're not listed as a provider during open enrollment for the next year, they're going to start asking questions. And so there is a strategic component within the timing. And that's why I generally run this every July to August. This is the time of year that I'm starting to put all this together for my practices to say, okay, who is going to get the termination notice? And who is the one that we're going to go ahead and terminate? And because sometimes they'll say, we will not consider a contract renegotiation unless it's been terminated. Because the anniversary date of the contract is not for another 2 years. And I'll say, fine, we'll terminate it. We'll send you notice of termination. One of the other things we want to look at, and if you're pretty good with Excel spreadsheet, this stuff builds on itself. You don't have to re-enter the numbers every single time. But in this one, I took payers 1 through 5. We can see what percent of revenue that they represent for this particular practice. And then I'm going to look and say, for payer 1, how many admin did we do? How many 99213s and 4s did we do? I'm going to look at the count by CPT code, by payer for the last 12 months. And I'm going to load them in here. What is their rate? And I'm going to look at their schedule, and I'm going to look and see how much business that practice represents. This is one of those exercises that helps you to understand who the payers are and what they're paying and so forth, and what the financial impact of those, what they are. And so in a similar vein, if I have a contract where I sent a notice of termination or we're renegotiating the rates, what I'm going to do is, for Chip Hart Managed Care Organization, who, I'm going to say I had 1,546 admin. This is what they're currently paying. This is what they're proposing. What is the net increase as a result of the new contract? And so here, I can very quickly ascertain whether or not there is an increase in the overall impact of the finances from being a provider for their members. Does that make sense? Yeah. You want to look at it within that patient population and see whether or not their proposed negotiated rate makes sense. On this, if these were the rates that I've been enduring, and I can look at it here and say, they're only going to pay me $1,900 percentage-wise. That's not a significant increase given the increase in expenses and everything else. Oftentimes, people will ask in your managed care contract that they will agree to pay you X% of Medicare. That ring a bell with anybody? So the question is, which year do you want as your contract? And what I have found, and Chip and I kind of looked at this, if you may recall, there was a significant bump in the 2021 fee schedule. There has been a consistent pattern, and in that bump came from the E&M, okay? They bumped up the RVUs for E&M, and that was a good thing for pediatrics. And so what we're finding is some of these contract renegotiations, they will increase your percentage of Medicare, but they may go and say, we will do it at a percentage of 2019 versus 2020, 21, 2022. And so the conclusion that we take away from this is some data that Chip had given me. We looked at all of this. We looked at the volume counts by year. We examined the impact on, how much, which is the best year. You really want a percent of Medicare after the year 2020. That's the most favorable. It was around, I believe, an 8% bump on, higher bump on the E&M, but that's really what you're shooting for if you have that option. That makes sense? So that's the ask. We want a percent of Medicare for any Medicare fee schedule after, starting with 2021 and on. It's better than 2019 and some of the others. I'm not going to, so this is actually, I'm going to finish 15 minutes earlier than I thought, but this is the last slide that I have. Have you ever gotten a contract and it just didn't make a whole lot of sense? And it's like all this legalese that sits in there makes it really difficult to understand. And this particular rule is translated, it basically says that the interpretation of any ambiguity should favor the party who did not draft the contract. So the reason for this is that it is taking the ambiguity, it's preventing an incentive for ambiguity. If I write a contract and and submit it to another individual and I fill it with a bunch of legalese to try to trip them up, this is what it's trying to prevent. And the reason it's going to discourage people from including vague terms, and it's also going to give the benefit of the doubt to the party that was required to sign the contract. So this is really something to think about when you have a potential dispute. For example, there was a practice I was working with where they said, we will pay you X% of then current Medicare rate. My interpretation of that is if we're in 2023, they will pay me that percent of the 2023 Medicare fee schedule. Slam dunk. And they said, no, that's not what it means. I'm like, yes, it does. Plain black and white. And it ended up to be a source of controversy with this particular payer. And eventually we worked it out. Okay? But just remember that oftentimes when you're looking at these contracts, and it doesn't make sense, or they're not willing, you end up in a dispute. This is a provision that actually the one who called my attention to this was Dr. Suzanne Berman. She says that this is pretty reliable, and if it doesn't make sense, then the ambiguity favors the person who's subject to practice when given a contract from the insurance company. The sample spreadsheet that we worked through, I think Chip showed you earlier one that was an abstraction worksheet, all the key terms in your contract. The ones that we went through today, the MCO grid, the payor CPT compensation, payor comparison, I mean, those are some technical things. And, you're welcome to scan the QR code. There's a bunch of other stuff there as well on the PMI website. And, you can kind of use that to no point in reinventing the wheel. If you do something that's pretty cool, send it to me. I'll be kind of curious to see what people do with them. I'm happy to answer any questions. Again, I promise you it's going to be short, and it ended up being shorter. So, but Bueller. Okay. Well, I'm going to go ahead and I'm going to turn this over to Chip to make the introduction for our final speaker of this. I love putting him on the spot. He's like, okay. So.
Good afternoon. Good afternoon. Puberty's hard. Let's just get your line up here. So, Kim Brennan runs a very large, very successful, and now newly owned pediatric practice in California. I will let her give a little bit. I meant Florida. I know where she is. I named a state. They both end with A. Yeah, no, I do. I'm like, no, it's hitting me so hard. In any event, when we were putting this all together with the AAP originally, we realized that to have me and then Paul and then Suzanne go, you've got a bunch of professional consultants talking to you about how other people do it. And we realized we needed to have someone come in to talk about how she did it. And so I know that, I mean, what Suzanne gave you was gold, all right? But that's not the same as actually talking to a person who did it. So this is good, great stuff. And I'm just going to pass it off. This is the proof in the pudding.
Hi, I'm Kim Brennan, and I'm the practice administrator for Palm Beach Pediatrics in Southeast Florida. I'm going to share, if you saw me, they may have over here, as Suzanne was talking, I'm like nodding my head, nodding my head, nodding my head. When you were talking, I'm nodding my head. When I came to our practice, I started in January of 2020, January 30th, literally 6 weeks before the world shut down. And so I had just started getting my bearings with this practice. And I've worked in pediatrics before. I've also worked in adult primary care, urology, behavioral health, but I had not contracted myself. And the contracts that I arrived to, some of which were last signed, there may have been some amendments, but the core contract, some were as old as 2004 or in 1999. And we still, to this day, have paper copies of them. I have scanned all of them, but we've kept the paper copies for what, purpose, I'm not quite sure. But since then, we have renegotiated to date United, Aetna, Cigna, Blue Cross, some smaller local payors that are local to our area. Some of those small payors, like someone was saying earlier, they're like 5% of our patients or less. And those are also leveraged because I can say to the payer, this is not enough of our patient volume to continue accepting these rates. So we're going to say bye-bye. And we did that recently with one, and we have a current negotiation going with one where we said, you're taking too long to respond. We've asked you multiple times for updates. Here's our termination letter. And they immediately said, here's your counter proposal. And it is about 15% more than what you originally asked us for. So you do have some leverage with those small payers too, because not many people want to work with them. They're not, at least in our area. We're in Florida. It's a little bit of the wild west, south, however you want to look at it. But we have done this, and they very much have spoken the truth. it is not necessarily easy. It is exhausting sometimes. It is cumbersome. It is really frustrating. But it is worth it. It absolutely is worth it. And it is really, really satisfying to finally get to that point where you feel like, do I ever feel like it's fair? No, because I feel very personally, strongly about the undercompensation of pediatricians and where that's leading us as a society, because it's not just affecting the people in this room and their employees and their patients. It's affecting everyone, and it's going to continue to do so. As I'm sure many of you all are aware, fewer medical students are electing to go into pediatrics when they're, matching with residency, and that has, in my opinion, very long-term negative implications just for our society at large. But I digress. I get on a payment soapbox a lot, so excuse me. So one of the things I did do when I joined this practice soon after, I did take a payer contracting certificate course through MGMA, which is a professional organization it stands for Medical Group Management Association. It's technically for groups, and we are a group. But when I joined MGMA and pursued my certification, I was working at a behavioral health organization running as the administrator for their medical department. So there's definitely some flexibility there. They're not typically turning away paying members, who work in the general realm of healthcare, who also want to pay for a certificate program. So they do a on-demand, you can do it all online, payer contracting certificate program. They're not paying me to talk about this, but it was super helpful for me. It helps me understand the importance of what Chip talks about and having your data ready. And I just found it very helpful. And it gave me that little boost of confidence to say, okay, I'm going to go. I'm going to do my first one. And I don't know if I'm just a glutton for punishment, but my first one was United Healthcare. So we are a medium-sized and growing independent practice. We have 9 physicians, 8 currently, but 1 hired starting in September, and that's kind of fluctuated. It's hovered around 9 for the last few years. 5 pediatric nurse practitioners, a psychiatric nurse practitioner, and I left her off this, a clinical psychologist who does psychological testing for us. And so we've also had a lot of experience credentialing and contracting behavioral health providers, which is a whole other challenge and unfair payment system, especially when you're attaching it to your primary care contract. We also integrate behavioral health with other community organizations, nonprofits, hospitals, the school system, pretty much anybody who will listen. Our practice about 40% of our patients have a confirmed mental health diagnosis, and that number just keeps growing. So it's very much a niche and a passion of our group. And then we're always looking for ways to pull financial levers, and contracting, very much so, is the easiest. It is the easiest way to spend, like Chip said, you said 4 hours, 10 hours, it might be 20 hours, it might be 30 hours over a year. But if that 30 hours results in a 10% increase in your revenue, it is paying leaps and bounds. So I will always fight for people to at least attempt this. At least attempt it. If you go to that first payer and you say, nope, I'm not going to be able to do what is needed, then bring in someone like Suzanne or Polly to help you with that process. But at least give it a try, because we tried it and I thought there's no way, but we've been successful with it. So in 2020, we had outdated, unorganized contracts. They were all kind of shoved in a file cabinet. Some of the folders were labeled, some were not. Some were group contracts, some were individual provider contracts. It was just a mess. We were hearing all the time, and this was also too before all the payers felt like they could just stop giving you time and meetings to speak about your performance, right? So we would hear in these meetings all the time, you are eligible for this amount, and here you are achieving like 2.5% of that. And we were very, very frustrated by that because we also knew that we were providing the care that was required to meet the measures, but we weren't billing it correctly, essentially, and that is a very big part of this. We had unresponsive payers, just like Suzanne said, they are trained to say no. About 2 to 3 years before I came to the practice, the owner and the director at the time had attempted to initiate some contract renegotiations. Pretty much everybody said no, and they did. They said, okay, they got like a very small increase with one payer, and they said, what they heard was, we're not considering fee schedule increases at this time. I very much align with Chip in that that's total BS. They can do anything with these contracts at any given time. It's their contract. They are the ones who drafted and negotiated it. And they don't hesitate to send you amendments in the middle of these terms to say, oh, by the way, we're not going to pay for this anymore. Oh, by the way, we're going to change this in your contract. And a lot of times they don't even require your acknowledgement of it. They just send it to you as an FYI. And you usually get it. It's an FYI. It says, if you don't want to do this, you can say that, but you have 30 days from the date that this letter was mailed to tell us. And where we are, we typically receive the letter sometimes 45 days after the date on the letter. So at that point, it does pay if you receive these by mail to save your envelopes because there's postmarks on there that you can really use to fight if you need to. Limited experience in contract and just negotiations in general. I had worked as a people manager for a long time. I had worked in healthcare for a long time, but I had not worked on the contracting side. I had done some negotiations with vendors, but not payers. And the practice prior to my arrival had just enrolled in, actually entered into a shared risk contract. So exactly what Suzanne was talking about earlier, it is a shared risk program. We are still in it. The contract looks different now, but it essentially says, here's your threshold for performance. If you perform here and you save us this amount of money as the payer, you get this percentage of that. And I'll tell you more about that as we go along. So now I had to redo these slides from when we did them in October because we've had some things change, and I want to give up-to-date info. We've also finalized some contracts since then. We've had huge success with that shared risk contract. It has not been easy, and it has been a little bit of the bane of my existence for the last, 4 years, but being as obsessed with it as I have been, I refuse for us to be in a deficit. I refuse to give a payer any more money than we already do day to day. So I am adamant that we will never get there. And we have a lot of strategies in place at our practice that I'll talk about to avoid that. We've increased all our major fee-for-service contracts, like I talked about. We've improved some of our internal billing department workflows to help identify those underpayments, where they're not paying us the contracted rates. We are not a PCC practice. I feel very awkward talking about that here, but we very much have a lot of respect for PCC. So we do use a different EHR, but we have a similar report in our system. It's called payment mismatch tracking, where it's essentially saying, this is what you're supposed to be paid, and this is what you're actually getting paid. And as Polly said, it is very rare that you are actually getting paid more than you're supposed to be. We've actually found that before, and we've taken it to the payer, and they're like, that's fine. Don't give us a refund. We'll just come back and take it from you one day, which they will, as we all know, probably 7 years from now. And then we also work with our billers to understand their workflows a little bit better, to kind of hone in on that, make it a little bit more efficient, and to change some of the settings in the back end of our documentation for the providers to automate some modifiers and things that just make it a little bit simpler for them. And the last part is probably the most important. As I said going into this, I did not have any confidence in what I was doing. That course gave me that little inch to say, okay, we're trying it. But every win we've achieved with a payer, if you want to call it that, I don't know that I ever really view it as a full win because I feel like there's always something lurking in the background there. But it has definitely increased our confidence in demanding what we know we deserve. Um, it has increased our confidence in sending a termination letter to payers, and it has increased our confidence in communicating with our patients why we're doing that, what it means for them, and what we need them to do if they want us to be able to continue accepting their insurance. So this slide in October said a percentage of profit, and our VBC profit decreased from 2022 to 2023 a little bit. So I changed this because it was less impactful, one, but I still want to share it because that is all profit outside of our fee for service. So any 1.3 in 2019% is a win, right? Because it's still 1.3%, whatever it was, in profit versus revenue. It's less, I'm sure. It was still more than what we had, so I always think people should fight for what they deserve, but something is also better than nothing. And so if your practice has experienced any of the challenges we have, like increased hourly rate for staff, that you have had no choice but to increase if you were going to remain competitive within your market, especially for nurses. That's been a challenge for us, and I think a lot of other practices the last few years. Um, but really, it's across the board. What we started a front desk person at in 2019 and 2020 is very, very different. What we look for in that person is also very different today. We used to look for a lot of professional office experience. Now we look for a lot of dependable people who have customer service experience because we found that a very customer service minded retail experienced person is much more effective at learning and mastering the front desk in our office than someone who has worked in a medical office maybe even the last 15, 20 years. We've kind of tapped other pools of candidates over the last few years and have been pleasantly surprised with some of them. And so you'll see, 2020 was the first year we were in that shared risk agreement. So we went from 1.3 to 4.5%. Still not that impactful, but if you think about it as 66% higher than the year before, then that is a big number. 2021 to 2020, also impactful. And these are all years where, and I accepted from that, like we definitely were tapping into the payroll protection program, the provider relief fund. I don't know many practices who weren't. We were included in that as well. So I tried to take that out of our revenue, thought just to show what the impact of the actual value-based care is. Now, this is where we see it change. So, and think about it as the revenue, a lot of it is for the performance from the year prior, right? So the payments lag for the prior year. This program specifically, we get paid quarterly out of some of the savings we've achieved for the payer, but the final reconciliation and payment for the year prior doesn't happen until September. So in September, we will get paid our final payment for the care we provided in 2023. So it is a long game also. And it's really frustrating at first because you're not seeing those big payments really in that first year of your contract. But you will start, if you're delayed that way, in year 2, you'll really start to reap the rewards. So in 2020, we had our first one. In 2021, we had that increase from 4.5% to 6%. And in 2021, we went into a new contract with a new model. And when we made that decision, we said, show us how we would have performed then. Take our 2022 numbers or 2020 numbers and plug it into this new contract you're proposing. And we were pretty shocked and agreed. And so you'll see in 2022, we went from 6% to 20% of our revenue being from value-based arrangements. And then in 2023, that increased to 24%. So, and this is only becoming more common. Now, it's hard to, a lot of the wins in value-based care come from like strength in numbers. So it doesn't have to be your contract, right? If you're in a CIN or an ACO. I will say we have one of those as well that we do with a local hospital, Joe DiMaggio Children's Memorial Health Network in our area. And they also have adult care in Memorial Health. And so when we, joined the CIM, we said, this is great. We want to help. We want to win together. You all are one of our strongest partners. But we also don't want to lose at the mercy of your adult Medicare physicians who do not pay the same attention to their contracts that we do and their performance. So we had some conversations about how we might account for that, how our measures would look different from those adult doctors, and why, because we would save them, we were able to show them data from other contracts to say, we can save you a lot of money, to say, well, we want to keep a bigger piece of our pie then, because we're also saving you money because we get paid less on fee-for-service than these other adult physicians do. So kind of where do I start? And this is how we did it. I'm not saying it's the right way. I'm not saying there even is a perfect way, but this is how we started. The first thing is we took those dusty old files and we just scanned the contracts into PDF versions. We put them all in a shared folder where we can access from anywhere. I work across my practice locations. We have a billing office. That's where my office actually is, but I could be at any office any day. And if I have a payer rep who's willing to get on a call with me, or if I have an email going, I do not want to have to call someone at that office where they are physically in that drawer and say, hey, you who've never touched a contract or even worked in billing in your life, can you pull this folder and try to interpret what it says on page 572? So taking our contracts and putting it, and we have separate folders for each payer because we do have different products and contracts sometimes for HMO versus PPO, things like that. So every payer gets a folder, and then if they have one contract, it goes in the folder. If they have 4 different fee schedules, that goes in the folder too. We just digitized everything to make it organized, less overwhelming, easy to access from anywhere. How do I keep up with it? This QR code will take you to this Google Sheet that is pretty much the same thing. But when you get there, you're going to have to save a copy of it because I have the original version locked that you can't edit it so that nobody puts their data in there and then everybody else can see it. Because we also don't want anybody getting, in trouble for breaking any antitrust laws. God forbid a pediatrician tell another pediatrician they're making 75 cents more on a 99213. That's the government and our commercial payers frown upon that. This will allow you to plug in. Some of these are already programmed for you, so you can start putting your info in, your effective date, your anniversary date, and then once you have your effective and anniversary date in there, your name, it's going to auto-calculate for you the days to your anniversary. You will have to put your term in and what your term notice is, but once you have that in there, it's going to red, yellow, green it for you. Oh, I'm sorry. I think I have it somewhere else, a link here too, but if not, we'll make you a new one and share it. It was working when I checked my slides too, so we'll double check. That notice notes column, I just put notes there for myself. That if we carved out any specific codes there, if we have something that we know we need to look at the next time we negotiate, something that I've picked up on an old contract or that I didn't really get that I wanted on a new one, and so that I have the note in there to remind myself for the next time. And then you can include some more detail. So I'll share that with you all before we wrap up. This is really, I had this listed out and when we did this at NCE originally, and I just tried to put it into like a little bit more of a easy, more fun to read format, I guess. I'll go over a few of these, but this is really kind of, if you're thinking about value-based contracts, which if you aren't, you should be. Like, this is what is happening all around us. It originally was just happening with Medicare and adult primary care. It's happening in specialist offices now. And if you're a primary care provider like we are, you are likely held responsible for the spending of your specialist colleagues. So we have found in this arrangement that it's really kind of like, as Suzanne was saying, there's a bucket for this and there's a bucket for that. There absolutely is. There's a bucket for hospital spending. There's a bucket for professional spending. There's a bucket for pharmaceuticals. We've analyzed our pharmaceuticals data, and 80% of that spending is prescribed by specialists. And that is including ADHD medication, also with the ADHD shortage, which has been a big argument of ours. The other thing that we found in analyzing our data is the amounts that are paid to other primary care practices for seeing our patients that are on our panel. So, and they'll say, oh, look at this, you have a non-loyal member. You're responsible for paying for this. And what I've said is, if they're assigned to us, but they're seeing another pediatrician, why are you paying the claim? Why are we responsible for your claim processing error? Because we're not. They're not supposed to pay that claim. And if they don't pay the claim, we don't get held accountable for the spending. So it's and when I asked that question to them, they don't have an answer. Oh, well, that's probably because that member is in a different plan. No, we're talking about a Medicaid HMO. Everybody has the same plan. None of them are supposed to see someone other than their primary care pediatrician. We agree with you. They should have seen us. We actually have record where we've called them 3 times and they haven't responded. But why are you paying them to see someone who's not their assigned primary care provider and then trying to charge us for it? So just paying attention to some of the stuff. What we found is that we know more about their value-based program than they do. They may, as an overall organization, appear to know more, but individual people involved in the process, the actuary, the market leader, our rep, the quality nurses, the value-based care team that comes on to talk to us, when we have questions for them, they do not ever in the moment have answers. And we task them with going to find it out. And usually what it comes back is, we looked into this. We can't really tell you why it happened, but here's a ticket number where we've put it in to correct it, and we're going to be crediting this amount back to you. And so we did that recently with some COVID testing that they just all of a sudden decided to stop paying attention to those things. That was $28,000 due back to us. That's a lot of money. So the notes for providers here, the way we communicate about this to our providers, one, we share their performance with them. So the members that you're seeing on this plan, this is your data. Do you have any questions about it? Do you feel like it's incorrect? Because you know your patients best and what you do for them day to day. So does that reflect what you're doing? Because if it doesn't, then we might just be looking at a coding issue, a billing issue, something that's very easily fixable. We also tell them this is where the bonus pool fills, right? Fee for service is not making any of us rich. And we do, however, want to provide financially responsible, appropriate clinical care. So we don't want to do just to do, right? Like, that's kind of the productivity model of, like, the more you do, the better off you are. That's not how we approach practice. We want to do what the guidelines and evidence in medicine suggest that we do. And we actually, our billing manager will sit down with them to do coding. She's a certified coder. We look at their E&M, coding to see, are you overcoding, are you undercoding? Not to say you're overcoding, we're slapping your hand, you're in trouble. To say you're overcoding, you're putting yourself at risk for your claims to be recouped. Let's look at what's missing from the mix. It may not be that it's not an appropriate code. It might be that your documentation didn't say you were coding based on time, something like that. So we have those conversations with them. So we try, and then the other thing we do is optimize our EHR to make it as easy as possible for them to do these things. So what do you want to remind you? Is it better to have a red alert over here? Is it better for us to put a flag in the chart? When you go into a patient's chart, it's there. Is it better to be in the quality tab? Or do you want us to as the manager, to send you a list of patients that have care gaps? So we have those conversations with them and make changes based off of their feedback. The notes for our staff who don't understand the quality performance piece of it as well is very simple. Empty visit slots plus care gap lists that we don't pay attention to equals lower performance for the payers. Lower performance equals less money. So that means less money for raises, holiday bonuses, other performance-based incentives. And we don't do that to say, if you don't do this, you're not getting rewarded. It's for us to say, if you don't do this, what could have been 5% might have to be 2%. Like, we would want to give you a merit increase, but if we're not performing well in these plans, it can't be at the same level. The Get Creative is, what I have here is anyone in your office can call patients to check in on them. Maybe not schedule, but our providers actually help us make these calls too. No one in your practice, myself included, our owner, all of us, no one is above helping kids to stay well, get vaccines, get the appropriate care they need when they're sick, and stay engaged in their medical home. That is everybody's job on our team. So we opened a new office last fall. It doubled in size when it moved. It went from a 2-provider office to a 4-provider office. Currently, we have 3 to 4 providers available. We sometimes put them in our other locations, but we have not built up the patient volume just yet to support doubling in size. Some of our providers there will have an hour chunk of time during the day. Okay, here's a list. Here's the list of members with this specific plan. These are the ones that are most concerning because they've either never seen us or, like in one case, we had a kid who had never seen us but had been to the ER 7 times this year so far. So it's like a monthly ER visit. And had also, in the ER, been diagnosed with asthma. Not where a child should be diagnosed with asthma, right? So and that kind of level of like misuse of healthcare resources and clear, like, not, just not understanding the resources that are available to them. It's very impactful to have a provider make that call and explain to them, like, if you have a kid who has never had access to high quality health care and you have a pediatrician or a pediatric nurse practitioner or whoever, call that parent and say, hi, your insurance says we're your new pediatrician. We were looking over some of the records and it looks like you really have not been getting the care that you should be. Like, that makes a difference. That's more impactful to a patient and family than saying, hey, we're new, it's great, come see us. You're ours now, even though you've gone somewhere else for 15 years. We also talk to them about, if you're not ours and you don't want to be ours, you don't have to be. You just have to call the insurance and tell them that. It's not, we're not going to force you to come to us, especially if you don't want to. And just paying attention, like I was talking about, to your measures, helping your providers make the connection of, does the way the payer says they're performing, does it actually reflect the care that they're giving day to day? They know, how are you really pushing? Are you having that HPV conversation a lot, or are you not? And then questioning everything, which it goes in the same kind of bucket. Like, does it make sense? Sometimes it's as simple as that. If I look at our quality data and I see that we're failing a measure that I know we're doing every single visit, I'm like, this doesn't make sense. Something is missing. And so for us in our state with Medicaid, we have the well visit, exercise counseling, nutrition counseling, BMI, depression screening, diagnosis code. There's probably 7 to 10, depending on the kid, diagnosis codes that might go on a well claim. Our state Medicaid can accept the top 4. So, but we're expected to do all 10. And we do. But we know we're always going to be okay on the well code, the, exercise, nutrition, BMI. But if we want to make sure we're hitting our depression screening measures and other items, we have to send in some notes. Is it stupid? Absolutely. It is stupid that we have to do that. But have we found some kind of efficient ways around it? One of those being they assigned us a quality nurse, and I said, hey, we don't have time to pull the notes for 2,000 children to send to you for the information that we already do. You visit our practice a lot. How about if we just give you a very limited scope access to our EHR? Can you go in and close those gaps for us if you have that? Sure, we can do that. So we've made those concessions, right? Like, do I really want to give, the quality nurse at the payor an EHR login? Will I do it if I can give her only what I want her to see? And it means that my billing staff doesn't have to fax records on 2,000 patients? Absolutely. I will do that. Fighting back, not being afraid. Your patients, your quality of care. Like, invite them into your office. We've done this. We had a vice president of a big Medicaid MCO that is not just in our state, so I'm sure many of you are familiar, who said, that's really great that you're doing all these things, but we don't really know how we're going to pay you for them because it's not on the Florida Medicaid practitioner fee schedule. And we said, okay, come to our office and see what it's like. See a couple of patients with one of our providers and see what you think. And they were just like, oh, this too was part of a downcoding issue we saw where we see all of that mental health in our practice. And so we code a lot of 4s and 5s. And we got the algorithm, downcoding happening. No one actually looked. We were just billing too many for what they thought was appropriate for pediatrics. And so we said, come see some patients with us. And they walked out and were like, you all could be billing all 5s. And it's like, okay, so now your job as payer, leader, market president, whatever you are, brouhaha, go fix your claim algorithm so that it's not affecting our practice. And it's very annoying. And my argument is always none of us should ever have to do any of these things, but we do if we want them to change. And it made my billing supervisor very happy because it's that many less claims that she has to then appeal because the code, they were inappropriately downcoded. Making payors help you, those meetings, that shared savings program we're in, we pretty much have forced monthly and quarterly meetings upon that payor and said, you're telling us that we're saving you a lot of money. Why would you not want to meet with us to go over our performance? It's not just our paycheck, it's yours too, and so they have. We have a monthly meeting that includes our provider relations rep, one of the few that exists anymore, and a quality nurse who's assigned to our practice. And then we ask that quarterly, they invite their value-based care team, their pharmacy team, and any other departments that they feel are appropriate to learn more about our practice or that we should learn from. And we have forged some really valuable relationships that way with leaders in that organization that when we aren't happy with the contract or something doesn't make sense, that we don't default to contacting them, but we have them as kind of that back pocket, card to play when we need it. The emailing, like Suzanne was talking about, I find it very annoying that talking about something that is important to a pediatric practice as your contracts and your fee schedules has to default to an online submission form because it's very much make or break for all of us. However, I agree with her in that it gives me a paper trail. And so our process typically is we'll email twice to reach out or send a proposal on the same thread. We do, delivery, confirmation, read receipt confirmation where they're telling us that they've read the email. We will follow up to say, We saw you read the email. Did you have any questions about the proposal we submitted? Things like that. And then for better or for worse, I'm very good at being annoying to them. I'm very persistent. I pulled out my early 20s like crazy ex-girlfriend hat and put that on one time and found a market director at a payer on LinkedIn and contacted her directly when her rep was being completely inappropriate. I very much believe what Chip said is they do not care about us, but I do not think me going into it with that attitude initially is very helpful. Another course I did through MGMA, which was at one of their conferences, was called Negotiation Ninja. And it was run by a woman who is a consultant who does insurance negotiations, but she has also worked for the FBI as a negotiation specialist. So, like, that mindset was very good to hear, because she's like, they are human. And I can promise you the person that you're talking to is not the person who is the decision maker. They are the first level contracting specialist, and they hate their job as much as you hate their job. You know, I have asked them, I know about one in Miami whose son plays travel soccer and all the challenges he's had this year with that. And outside of just caring about kids in general, I could care less. But I know that information, and I have something to talk with her about. I know that one of my contracting reps just moved to the Orlando area because she had a new granddaughter. Like things like that, just asking those questions when they've said no. I'm like, I understand that's really hard for you, that we're sending you a request that you've probably been told you have to deny, but we feel really strongly that if you can't work with us, we're going to have to term our contract, and we really don't want to have to do that to your members. We do not want to create the confusion and the disruption in care and just the dissatisfaction of your membership by having to send a letter telling them we're terming our contract if we can avoid it. Is there anything we can do? And a lot of times they will. Being realistic in, like, when I was saying, like, anyone in our office is not above scheduling, that doesn't mean all of them care and agree with that. So I'm happy if I get a third of people in our practice. We have about 60 employees in addition to all of our staff. And then, I have some that we've really taken the time to explain to them why this work is important, that it's how we ensure that our patients are receiving high quality care, and they connect with that. They do not connect with, here's a spreadsheet, call everyone and put your notes in this column, right? That is like a, why are you giving me this task? What they do care about is that we as a practice are treated fairly by payers, because we've been very open with them about how unfair it can be. They care that our families and our patients are taken care of, and that they do not have to be the ones to have the phone conversations when we mail those letters and the parents call. So they do not want to have to answer those questions and deal with those upset families. And that has helped engage them in helping us do this work. We have medical assistants who have done, care gap outreach. We have front desk. We have care coordinators. We have providers, myself, the practice owner, her children. Like, everybody in our practice has at some point touched these efforts. We email these patients. We send them text messages. We send them a postcard welcoming them to our practice and telling them everything that's great about it when they are first assigned to us on a Medicaid plan. Just a quick little, whatever, stamps are expensive now. We use postcards because it's less expensive to mail, but here's our locations. Here's all the great things we offer. Mental health, we're a PCMH. We have evening off hours. We have weekend hours. We do well visits on Saturdays and in the evenings. These are all the great things. If you still feel like you want to see the pediatrician you've seen the last 10 years, here's the steps you need to take to make sure that can happen. And they get themselves off our roster that way, because they don't want to lose the ability to see their preferred provider. The last few items here are just some sample documents that we've used. And so they should be in the slides in the app, I'm assuming, as well. I'll make sure that I get an updated QR code. I'll probably post it on the wall in the app also, and then maybe give it to Chip to push out also. But this is a negotiation initiation letter. As Chip was saying, they don't care much about this, but it gives us something to fall back on when they say no. What we don't include here in that initial conversation usually is the actual data on either how our expenses have increased, how our quality performance has improved, or how like our assigned member roster has increased, something like that. We use that for when they say no and say, really? Because we've done this in the last year that has helped your membership. Do you really want to sever our relationship? This is kind of a sample fee schedule proposal. And like Suzanne was saying, just give them what they want to see. So we do send that letter, but we send this as an attachment to it, which is pretty much like the primary fee source is that base fee schedule. So am I asking for the Aetna market fee schedule? I know what that is very well. The Medicare fee schedule, what do I want my base to be? I'm going to propose that it's, current Medicare typically, but they very rarely do that. Schedule A, B, C, and D. So that could be like Schedule A is PPO, Schedule B is HMO, Schedule C is something else, like that could be a lot of different things. It could be services. So I want this for E&M services. I want this for my well visit. I want this for my labs, my point of care, and I want this for whatever. Weekends and evenings, 990 and 99050 and 051, which we've fought a lot about with our payers too. This is a sample letter when we have termed with a payer, just if you ever have to do that, what we say to ours. It's typically pretty similar. It might have some nuances to what's happened in our contract negotiations. And we always highlight, bold that line that we are still open to servicing your membership if you are able to present an appropriate payment arrangement to us. We only have had 2 small lines of business with one payer where we've actually had to term. Every payer that we've sent this to otherwise has worked with us. And so I do not like encouraging people to play the game of chicken with your payers at the expense of your patients, but if you get to that point, it is effective. And this is a sample letter to our families. And what we try to do is say, this is what we've tried to do with your insurance company. Unfortunately, this is, what they've said. They're not going to agree. And then we break it down in kind of like an FAQ, like what this means for you. Can my child still see your practice? Can you still see them prior to this date? What the dates are around the termination? How do I start care with another pediatrician if I do, decide to do that? And we've also, this also addresses us, if it's commercial, which it typically is, encouraging them to call their HR department, their insurance company, and express their displeasure with this decision. And we've been open for 40 years. We have a very loyal patient base, some multi-generational families that kind of are our go-tos to fight on our behalf for a lot of things. And they're also our go-tos that we use like to help us improve our practice. So like we rely on them to be honest with us with their feedback. And so they typically are very loud. We would also probably send this to, if we know the employers, to the HR departments ourselves. Where we are, Palm Beach County is one of the largest school districts in the country. So like we know which payer has that relationship. There's a payer that has a relationship to service all the Palm Beach County employees, including the county commissioners, who we happen to have relationships with some of them. We have state legislators that live in our area, which most of you likely do, and like their kids might come to your practice. And so there are those relationships probably within your practice. And when you send this kind of letter out, they all kind of rise to the top because they are very good at arguing. This is the link for that same sheet. So if I'll test this too, and if it's not working, it did. Okay, and so that's in the slides. Perfect. Stupid QR code. And these are just some references from all of our conversations, some of the references from Chip's blog about, people who have achieved this. I just really want you to know, I know it's kind of boring to present on contracts. Like, that is not an exciting topic unless you're an attorney. But it is very important, and I'm happy to answer questions. I'm happy to, like, if you're getting that email that's like, we said we're going to propose this, what does that mean? I'm happy to give you a spreadsheet I use that does exactly what Polly's spreadsheet does, where if a payer gives me a proposal, I plug it in so that I can see in black and white, this is the amount of the increase, this is how it compares to current Medicare rates, and it averages at the bottom to say it's an overall 5% increase. The only other thing I want to share is Suzanne's comment on escalators. She is the one that turned me on to asking for those with my contracts, and they're funny. Some payers are like, okay, fine, and they give them. One payer that I had spent a lot of time annoying, it had been a year. We started a negotiation well before our contract was due to renew, and when they said, no, we're not talking until next May, we said, you're costing our practice money at this point. We're not willing to do that. So we went ahead and submitted a term for the end of that contract year. And they said, 6 months before it was going to end, they said, okay, we're ready to talk now. Because we don't want you to start emailing our members and telling them that you're trying. So that payer specifically, we went back and forth a number of times, probably 5 or 6 times. And at the end, we said, we want these escalators. And that woman was so annoyed with me at that point. She said, forget the escalators, forget it. We'll give you 3 years, a 10% increase. Will you sign it today? And I said, absolutely. So that was 10% across the board, all codes, their market fee schedule, which I already had. I went in, plugged it in. What's it look like if everything's 10% higher? It looks pretty good. So yes, we'll do that. But being persistent is the nice way to say it. Annoying, stalkerish. That's what I do to our payers, and I am sad to say it's effective. But if I can help any of you, I'm happy to. Thank you for listening to this what to most people is a very boring topic, but to me is I'm passionate about, and it works, and I want to help other people do what we've done because every practice in here can do it. So thank you. I think that's it. We lost Chip. Do you all have any questions? Do you all have any opinion, just curious, my question, on resources in addition to what we've given you that would be helpful in doing this and having these conversations with payers? What would make you feel better equipped to start them? Yeah.
I guess for me, not having any experience with contracts, maybe specific parts of the contracts to look for
Mm-hmm.
as to like what's wrong with this specific thing, or to look for a specific item in there. That would be a good indication that it's.
Yes.
Sorry.
Yes.
Yeah.
That's a very good ask because it definitely exists. We've had that scenario where it's been, we'll increase you this extraordinary amount on the well visits and we'll decrease the sick. We've had them play those games. And we've pretty much gone, and it does matter though. Like, we don't want to balk at a decrease in something if it means that there's a big increase to something that benefits us more. So like, if I'm going to get a decrease to wart removal, but it's going to be a big increase in my well visits, okay, we'll talk about that. It's probably going to work. So that's where having those codes and, like Chip said, all your codes, not for us, like it's not even just our top 20, because sometimes they will offer the decrease on the code that we billed 3 times, and they would offer an increase on a code, but if we're not looking at it, in that Excel format, we would never pick that out. It also would look a lot better when they've tried to shortchange us, right? When they've said, we're going to give you this much for these things, but we're going to decrease this and we're going to pay you 30% of Medicare for point of care lab testing, not even enough to cover the shipping on it, much less the test. So that, I'm going to think about like the sections of the contract that we've seen. Most of it lies in the fee schedule amendments though. And most of the fee schedules are an amendment. They are not in the material structure of your contract. So those terms, like Chip said, don't really matter because they can amend a contract at any time, and they do on their behalf. Do you have a question?
Yeah, so Chip talked about getting data out of PCC and how your well visit rates compare to HEDIS standards and things like that. One of the things that you mentioned was that I think you said 80% of your pharmacy costs were written by specialists, right? So that's data that's not in our EHR. There's data like, what are my patients' ER utilization rates and urgent care utilization rates compared to other pediatricians in my area. So I struggle with how do I get that data? If I'm not in a bigger organization like an ACO or a CIN that can track that for me, how do I come up with that? Like, I mean, I can compare myself to HEDIS, but if I have that other data, it's more, the more information.
And the payors have it.
They're
looking at it. Yeah. I mean, a lot of our payors, it's available. I mean, it's worth checking first to see if they have it available on a portal, because a lot of them do. A lot of them have ER utilization, hospital admission rates. It's built into their, payer portals that your billers are using to look up what's happening with claims, that your insurance verification, is happening through. So some of it may be there. It's annoying that it's all in different places, right? So you have to get it from each individual payer. But to us, we know who our big players are, so that's who we focus on. I'm not going to go worry about the ER utilization rates for the 5% of the population. I'm worrying about the Medicaid plan that we have 3,000 members, for that. I want to see that data that we have a shared risk arrangement with. I want to see the data for those commercial plans that were in the CIN. And we've also gone to our CIN and said, you're giving us data late because you get it from the payer, you filter it through, and then you get it to us. Can we not just get it ourselves? Like, can you give us access to get it? And they've been like, sure, it's less work for us. So they've given us access to some of their dashboards too. But with the specialist, we've used that in conversations with some of our specialists that have been long, decades preferred specialists in our area and said, listen, you may not get paid this way, but this is how we get paid. And we've been referring patients to your practice for 25 years. You've got to work with us here, or we have to start sending patients somewhere else. And at that point, they're very quick. And what most of them have said is, I had no idea when I prescribed Humira that it negatively impacted you financially. They just are not aware. The payers are not telling them that. When you do this, the drug reps that are, getting them onto these drugs are certainly not telling them that. But when we've said, like, when you make here's your decisions, A, B, and C, and you make A and B, our practice might actually lose money because of that. They're mortified, because they value the relationship. Some don't care, and we've had those conversations within our practice amongst myself and all of our providers in one of our, meetings to say, how do we feel about this? Like, is this specialist, is the fact that we have his cell phone number so important to us that we're willing to continue, or you as a pediatrician or nurse practitioner, is it worth it to you to possibly lose money, lose future bonuses, lose future increases to continue to prioritize this specialist relationship? It's probably not. But most of them have been very, collaborative and a little embarrassed because they've said, oh, I was just doing it, because I thought it's a new drug, like, we'll give it a try. And we've also shared with them, In our practice, one of the things we've done to help our pharmacy spending with our Medicaid plan is we've created text macros that have, for ADHD specifically, a tier 1 and a tier 2 options for our providers so that it makes it very easy for them to choose. So they'll type in ADHD formulary and in their text macro, and it will pull up for them like, here's the top 5 drugs on tier 1, here's the top 5 drugs on tier 2. Is it appropriate to try these first? We're never, ever going to say to them, change a child that is stable on medication, and we are never going to say, if you have a drug that you know is going to work for this kid, choose these instead. But in every opportunity you have that you feel it's appropriate, please use these lists. And that went in that value-based program. We struggled for like 2 years. We were at 75% generic prescribing. We're like, we're pushing this. As soon as we implemented those text macros, we went to 77% for 2 months, 78 for 2 months, 80 for 2 months, and we've been at 82 for the last 3 months. So we're 82% generic prescribing for those members now. But that's data that the payer gives us. Yeah. Any other questions? Well, I hope it was helpful, even if it's contracting is very boring. Chip, do you have any closing remarks?
First, great job, Kim. Thank you.
Thanks.
So she's not a paid consultant who gets to do this and walk away from it if it doesn't work. You saw how it can happen with a real person. Anyone here feel motivated to do this when they get home? That's what we want. Now you see right here on this page where I talk about success stories about people doing this. That's just from when someone emails me and they tell me something that I hadn't heard before, and I just write a little note about it. And I write up a small fraction of the times that it works. Like I didn't do David Allen's story, all right? I just was busy. But I want to hear the stories because I do gather them. In fact, that's why I started the blog originally. That's why it says Hello World 3. That was literally my first blog entry like 10 years ago. I really want to hear about your successes. I want to hear when it doesn't work because we share this information. You might tell me something and say, it didn't work, this is what happened. And I might be able to say, well, guess what? I just heard from someone else that you need to try this. So please share that information, share it on PCC Talk, share it on SOAPM, and just do it. Meanwhile, we have, I think, one more little bit, and then we've got the big bash, and everyone's got costumes, I hope. It's okay if you don't. Some of us do. Anyway, that's it. Thank you, everyone. I'm going to turn to the camera. Thank you. Bye.